So good morning. I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of September 17, 2025 to order at approximately 8:04 a.m. Pacific. Melissa, if you could please call roll.
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns.
Present.
Dan Hartung is excused. Lori Hoagland.
Present.
Dan Kennedy.
Present.
Chris Lehman.
Present.
John Murray.
Present.
We have a quorum.
Perfect. Thank you, Melissa. In addition, we welcome everyone to today's meeting. We also have an American Sign Language interpreter here with us today. Please use the Zoom controls to access the interpretation channel. And Melissa, thank you for putting that information on the screen. Let's go ahead and keep that on while I move to our discussion related to real or potential conflicts of interest, just to give people time to see the directions. So our agenda begins today with a conflict of interest declaration, which is stated at the beginning of each month according to board policies. Do board members have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities? And or have board members provided testimony to the Oregon legislature related to prescription drugs? Mr. John Murray, I do see your hand is raised. So Mr. Murray, you have the floor. Although we cannot hear you.
Thank you. Thank you, Chair Bailey. Under advisement from the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs Incorporated, comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBMs, insurance companies in the state of Oregon. Using the language of the Ethics Commission, because the PDAB is an advisory board that simply provides information to others who have rulemaking authority, guidance from OJAC is that it appears that at most you would have a potential conflict of interest each time the PDAB meets to discuss a specific prescription drug or related matters. And I guess I would also pass on that I did ask questions of Trevor Douglas of OHA concerning ArrayRx, the operations of that entity, and the PBM that is associated with it. So it was purely informational. Thank you,
Mr. Murray. Since you did add that additional piece of color, could you share for the record what group or forum that discussion was related to, just for any additional visibility?
Sure. Yes, it had to do with one of my recommendations about a single PBM serving Medicaid and CCOs in the state of Oregon, its capability, its likelihood, its details of how it might possibly work or not work.
Oh, thank you. I guess I meant more what was the forum or group, less of what was said.
Oh, I'm sorry. I attended also a quarterly report or a quarterly pharmacy meeting sponsored by OHA.
Okay, perfect. That was all for the record I thought might be helpful. Thank you, Mr. Murray, for that additional content. Does anyone else have any declarations they want to share at this time? All right, with me seeing no further declarations, I do want to move forward to asking my colleagues if anyone has any changes to the draft minutes from the August 20th, 2025 meeting that you would like to have edited. Mr. Murray, your hand is raised. You have the floor.
I would make a motion to approve the minutes as presented, please.
Thank you. Do we have a second?
I'll second. This is Board Member Kennedy.
Thank you. So Melissa, can you please call roll to approve the minutes from the August 20th, 2025 meeting?
Lori Hoagland.
I was not there, so I cannot approve.
Okay, you abstain?
Yes.
Okay. Okay, thank you. Dan Kennedy.
Yes.
Chris Lehman.
Aye.
John Murray.
Aye.
Vice Chair Amy Burns.
I abstain.
And Chair Shelley Bailey.
Aye.
Okay, we do not have enough votes to approve the minutes, so we could bring those back next month, possibly.
I would want to ask staff for guidance related to that, because the only reason why we didn't have an approval of the minutes, in my understanding, was because of two individuals who were not in attendance, right? So we did have quorum. So you're right, Melissa. I guess can we move to approve the meetings next month when we have the board member who was in attendance?
Yes, we'll put that on next month's agenda.
Okay, as long as that's in alignment with our policies and procedures, please document that for the record for our October meeting.
Okay.
So then moving forward, I would like to call on Courtney Whitlock, Senior Policy Analyst, to provide us with a program update. Welcome, Courtney, and you have the floor.
Yes, thank you. Good morning, Chair Bailey, members of the board. I'd like to provide just a brief update on the program. We are pleased to announce that Sarah Young will be joining as the next Executive Director of the Prescription Drug Affordability Board and the Drug Price Transparency Program. Sarah comes from the Federal Office of Rural Health and Policy, where she directed the Policy Research Division. She brings experience in policy analysis, data analysts, rural hospital policy, and program development. Sarah also holds a master's in public health from Portland State University and will officially begin her role on October 6th. Additionally, a new board member has been selected and awaiting the Senate confirmation hearing at the end of the month. The candidate is Michelle Coder, the pharmacy director of the Mount Loma County Health Department. Michelle brings expertise in clinical pharmacy, medical managed care, budget development, and health policy. Her first meeting with the board will be October 15th. There are also 3 board members that were up for reappointment. Dr. Dan Hartung, he is the professor of pharmacy and research at Oregon State University. Dr. Chris Lehman, vice president of the strategy and pharmacist at Columbia Memorial Hospital, and Dan Kennedy, retired pharmacist from Providence Health Plan and currently president of the Oregon Pharmacy Association. And then each of the reappointment members will be serving a 4-year term ending December 31st, 2029. With these updates, the board will now include Chair Shelley Bailey, Vice Chair Amy Burns, John Murray, Lori Hoagland, and the newly appointed Michelle Coder, and the reappointed members, Dr. Hartung, Dr. Lehman, and Dan Kennedy. Lastly, just a highlight of some news. The Ninth Court Circuit on August 26th issued a ruling in Pharma versus Stoffe, upholding Oregon's House Bill 4005, which is the drug price transparency law. HB 4005 requires prescription drug manufacturers to report information related to certain prescription drugs to the Oregon Department of Consumer Business and Service the Drug Price Transparency Program. The court found that the manufacturer reporting requirements are constitutionally under the First Amendment and do not constitute as a taking under the Fifth Amendment. So this decision affirms that the state's ability to collect price increase data from manufacturers, which is an element in the PDAB's work under Senate Bill 844. And with that, Chair Bailey, I will send it back to you.
Courtney, thank you for the program updates. We're now moving to the public comment period for general public comments. Later in this meeting, we will have public comment time related to the prescription drugs under review today. For general public comment, the board received 11 written comments, which are posted on the website. I will go ahead and read those now. Those were from Tiffany Westrick Roberson from Each Pick Coalition. She sent 2 letters. From Ashir Vantris from AIMED Alliance. From Nisa Shafai, Allergy Asthma Network. Dr. Harry Gawanter from Let My Doctor Decide Action Network. Bill Head from the Pharmaceutical Care Management Association. Rainier Simmons from CAN. John Mullen and OCAP Board. Brian Mayo from the Oregon State Pharmacist Association. Marianne Cooper from Regents Blue Cross Blue Shield of Oregon. Lauren Sant from the Caring Ambassadors Program, as well as a comment from Jennifer Hazen. The board also received 7 requests to speak today. I will call on each individual who signed up to speak and ask them to state their name and organization. They will have 3 minutes to speak. As a reminder, the board does not deliberate on issues or requests during this time. The individual I have first on my list is Primo Castro from Biotechnology Innovation Organization, also known as BIO. Primo Castro, if you are here, welcome and you have the floor. Melissa, have you heard from Primo Castro related to public comment today?
Primo is here, and Primo, I did change your settings, so you can turn on your mic and camera.
Great, thank you very much. Sorry, apologies, board. Just I'm gonna have to be off video just because I'm having a little bit of internet connectivity issues. So if I cut off, just you'll understand why. Dear board members, the Biotechnology Innovation Organization, commonly known as BIO, appreciates the opportunity to provide comments today. Comments were passed on, I think, at last meetings. Submitted ahead of last meeting also and stuff. So these meetings today, these talking points are from last time. Bio has long argued that the board's premise behind establishing a drug review process is flawed. An overt focus on cost savings that patient value will harm patient access to life-saving medications while failing to protect patients from harmful coverage restrictions imposed by plans and PBMs. The drug review scoring framework arguments these concerns by assigning products as unaffordable rather than examining the system that determines whether patients can access a given product. Whether or not a product is covered, the patient's out-of-pocket costs and benefit design are determined by health plans and PBMs. Drugs deemed to be unaffordable may shift market-based access incentives and lead payers to reform their benefit design. This in turn may reduce patient access to those medications. Patients who visit small provider practices and specialty providers in rural communities may be disproportionately harmed if those providers cannot or will not access these drugs anymore because reimbursement for associated services is limited. Bio is also concerned by the lack of scientific rigor of the drug review scoring framework, which has never been vetted publicly or validated in any way, as drugs are given a score of 0 to 3 based on minimal to severe impact. There is no clear indication of how value is determined and instead relies on subjective interpretation. Throughout the materials, it is evident that Medicare data is repeatedly reference, including a comparison of Medicare cost per enrollee. This reference contradicts prior board discussions, which several members agree that Medicare data is irrelevant to the board's work and would create data inaccuracies as Medicare benefit design and coverage paradigm is significantly different than commercial and Medicaid coverage. Please note that our comments on the drug review scoring framework is not an endorsement of the board's actions, and Bio's position still remains that the board should not implement its affordability review process. Thank you.
Chair Bailey, you're on mute. And
My apologies.
also, I do not see Bill Head in the meeting. So if
Thank you
Bill
for
is
letting me
here,
know. I do have Lauren Sant on my list next, so I'll go ahead and circle back for Bill Head at the end of the session. But Lauren Sant from Caring Ambassadors Program, if you are here, welcome. You have the floor and you have 3 minutes.
Good morning, Chair Bailey and board members. My name is Lauren Sant with the Caring Ambassadors Program in Oregon City, Oregon. First, I do want to thank you for all your hard work that you're doing. I'm really glad to see that you're addressing trade secrets and confidentiality and proprietary information from manufacturers to garner the critical points that you need to address affordability. I just have a question about it is like once this process is adopted, will you update the cost information to reflect what plans and Oregonians are actually paying for their prescriptions? And will the board have sufficient time to discuss those changes before making any decisions on the drugs being reviewed? The policy recommendations that you made are really refreshing, and they reflect that the board understands that prescription drug costs are just part of the supply chain and that ultimately leads to high-priced drugs. As these recommendations have pointed out, there are numerous opportunities outside of your current authority to reduce costs and to both the patients and the state. And I hope that you'll consider 2 additional recommendations. It would be great if PDAB members were authorized and encouraged to interact with public testimony. And it would be great if you established a stakeholder advisory board to assist PDAB members and the DCBS staff. And this last recommendation is because patient and provider engagement is still lacking in your reports, especially provider. Every drug under review has that you have no information from providers. And given that you have extra time on your agenda, I would hope that maybe you'd invite some providers to present their perspectives to further elucidate the information that you have. I'm really glad to see the changes to the rubric. However, I don't see any changes in the therapeutic alternative scoring. Again, therapeutic alternatives are not equal. And this is really based on dollars being the prize winner and not the patient being considered. So take a look at how that scoring is done. It's not a patient-centered approach. And in closing, my last suggestion is that our world has changed dramatically. The cuts that are coming to the Oregon healthcare plan are going to be absolutely catastrophic. And I would hope that maybe you would ask is a recommendation that you get to expand your compass and look at all the drugs, all the drug costs, the whole system, and how the drug costs are utilized, and help the legislators to navigate these changes to avoid minimizing disruptions to Oregonians living with chronic diseases. They need your help, and you have the expertise. So maybe this board should shift to just helping make those changes be the least harmful. Thank you very much, and thanks for all your work. Have a great day.
Thank you, Ms. Stamp. The next individual that I have on the list here is Jessica McBride from the Oregon Coalition for Affordable Prescriptions. Jessica, if you're here, welcome, and you have the floor.
Hello, thank you. Good morning, and thank you for the opportunity to comment today. My name is Jessica McBride, and I'm here on behalf of the Oregon Coalition for Affordable Prescriptions, or OCAP. We believe that prescription drugs must be affordable and accessible for every Oregonian. And right now, people in our state are struggling. According to the Oregon Health Insurance Survey, in 2024, more than 150,000 Oregonians delayed filling a prescription in 2024 because of cost, and nearly 160,000 skipped or reduced medication to make it last longer. At the same time, we've got powerful industry players who are working to tilt the rules in their favor. According to a recent Wall Street Journal article, there are two provisions in HR 1, or that big, beautiful bill that was signed into law this summer that will directly affect prescription drug prices for consumers. First, drugs that were initially approved as orphan drugs and then later received broader non-orphan approval. The negotiation clock now restarts at that later approval, further delaying eligibility for Medicare negotiations. And the second exempts drugs that have been approved only for multiple orphan indications from negotiations altogether. The Congressional Budget Office estimated that these carve-outs will cost Medicare at least $5 billion over the next 10 years, but the true number is likely much higher, as the office is currently reevaluating their analysis after having left out some key prescription drugs. We also want to comment on some of the policy recommendations or topics for discussion, and recognize the importance of examining pharmacy benefit managers. They do need oversight, and PBMs are not the only driver of high drug costs. Brand name manufacturers continue to raise prices above inflation, stack patents, overuse the orphan drug designation, and spend millions lobbying for carve-outs like those in HR 1. Unless we take a comprehensive approach to the entire supply chain system, patients will keep paying the price. We urge you to broaden your scope, act with urgency, and use all the tools available, including resources like the white paper that we attached, linked in our comments, from the Harvard and Brigham and Women's portal, to ensure that your affordability reviews are efficient and effective. People of Oregon cannot wait. Thank you.
Thank you for your time. The next individual we have on our list here is Daria McGrew from Pharma. Daria, if you are here, welcome, and you have the floor.
Good morning, Chair Bailey, members of the committee. Thank you very much. Daria McGrew on behalf of Pharma. First, encouraged to see the agenda today. includes the upcoming discussion about confidentiality problems that the board is facing. Pharma has previously requested that the board develop a process for the receipt and handling of proprietary and confidential information. The board's processes should incorporate mechanisms by which manufacturers and other stakeholders can safely provide confidential information, ensuring that it is protected against improper disclosure or use as required in light of the obligations imposed by both federal and state law. For the policy recommendations, we're pleased to see that the board members are expressing an interest in policies that consider drivers of affordability broadly across the supply chain and outside of the more narrow focus as currently looking at. Look forward to your discussions on the issue. Next, I want to reiterate concerns with the draft scoring rubric. Creating such a rubric is a positive step in providing a consistent method for evaluating drug affordability, but the framework continues to use vague and inconsistent terminology. The board needs to clearly describe the rationale for all the categories, in particularly any questions where quantitative cutoffs are chosen so that they're not completely arbitrary. And again, I want to express, similar to last month, general questions about the review packets. We continue to request a comprehensive data dictionary to clarify terms that are inconsistently used or misunderstood. There is inconsistent usage of payer spend, plan spend, total cost to the healthcare system, net cost, and gross costs. Having insight on the net cost of a drug is a critical element in your affordability review. However, the reports offer conflicting data in different tables. It is particularly evident in this group of reviews this month, where there are significant price concessions reported in tables 7 and 8, and further tables showing supposed net price, according to the footnotes, don't reflect the numbers that are reported earlier in the report. So internal inconsistency within the reports where tables are not matching each other, and the board should look into why the numbers are not mathing, why the math isn't mathing and they're not matching each other. So thank you for considering these comments. Thank you.
Thank you. The next individual I have on the list to provide public comment is Tiffany Westrick Roberson from the HPIC Coalition. Welcome, Tiffany. You have 3 minutes and you have the floor.
Chair Bailey, Vanessa Lathan was speaking instead of Tiffany, but Vanessa is not in the meeting. And same with Bill Head, who's coming up. So if either of them are in the meeting, they could raise their hand in Zoom. That would be helpful.
I appreciate it. So then we will move to the last speaker that I have identified on my list, and that is Lugenia Mendez Harper. Lugenia, welcome. You have the floor.
Hello there. Can you hear me?
We sure can. Thank you.
Okay. I just want to make sure I was on the right thing. Good morning, Chair Bailey and members of the Oregon Prescription Drug Affordability Board. My name is Dr. Lugenia Mendez Harper. I'm a pharmacist and state government affairs principal with Prime Therapeutics. We are a pharmacy benefit manager that's owned by 19 Blue Cross Blue Shield plans across the United States. And we administer pharmacy benefits for millions of people across the nation, including Oregonians, serviced by Regents. It's been my pleasure to have worked in Oregon for the last several legislative sessions dating back to the 2018 Fair Pricing Prescription Drug Task Force, so HB 4005, which was mentioned earlier this morning. I've also had the honor of serving on the New Mexico Board of Pharmacy for several years. And I share these experiences as both instances where I was asked to serve on a board or a committee or a task force in my professional capacity. And that service on those boards was driven by a specific mission or charge. So, for example, in the instance of the boards of pharmacy, we regulate the profession to protect the public health. And there are many times when you're operating as a board of pharmacy member where you have to stop and think back, okay, what is the mission of the underlying mission or charge of this organization? Because it serves as a really helpful guidepost for the activities of the organization. The reason that I mentioned that is that the underlying directive of PDAB is to protect a variety of stakeholders, I would say all stakeholders in the state of Oregon, from the high cost of prescription drugs and also to provide legislative recommendations for legislative changes necessary to make prescription drugs more affordable in the state. So I wanted to respectfully request that PDAB keep in mind the underlying mission of PDAB of protecting Oregonians from high drug prices as you contemplate the 2025 policy recommendations that have been put forth for discussion later today in this meeting. So I want to thank you for your time and all the hard work of the PDAB. Certainly want to remain as a resource for you, both from the PBM perspective, as well as historically having been involved in Oregonian legislation and policy making regarding drug pricing for the last several years. Thank you so much for your time, and look forward to working with you.
Thank you for being here today. Before we move to our discussion on trade secret information, I do want to circle back, Vanessa, and see if Bill Head is in attendance from PCMA.
Oh, we have two more. Bill Head is not here, but we have two more speakers. Vanessa Lathan has arrived, and Derek Flowers is also on the list. Chair Bailey.
Okay. I may have a older version of the notes. The second speaker, please, can you reference their name again?
Derek Flowers.
Thank you. So we will now request that if Vanessa Latham is here, welcome. And Vanessa, you would have the floor.
Thank you. Give me a moment, please. I apologize. For being a little tired. I don't know why I thought it was 12 Eastern versus 11. Please give me a moment. Hello, my name is Vanessa Lathan, and I am speaking on behalf of the Patient Inclusion Council, which is a national council that represents patients and caregivers across the country who are concerned about medication affordability and access. We bring together patients on the drugs being reviewed by your board to share their feedback and their concern about the process. We also represent caregivers, and our Patient Inclusion Council represents all health conditions, acute, rare, and chronic. We urge the board to slow down the process of your review and look at how your review process could negatively impact patients, particularly how patients have been involved in the process and the medications that are being selected. We also want to be mindful to protect vulnerable populations and make sure their concerns are heard in this process. We don't want any unintentional consequences like medical switching or reduced access, which will fall hard on certain communities who will face increased barriers. We want to make sure that these processes are covering all possible negative outcomes before making any concrete decisions. The patient voice, the caregiver voice must be centered in every step of the process. We have a patient survey. Our pilot results are out. We ask that you review those, partner with those, and we are currently doing another survey that is engaging patients and caregivers across the country around medication affordability, medication challenges, as well as affordability success. We ask that you look at PIC and EACH as partners in this process. We want to continue to create robust opportunities such as patient roundtables and listening sessions so there is meaningful engagement of people with lived experience at the table to inform decisions. Finally, affordability must be defined by whether patients can access it and adhere to the medications, not just by symptom level costs. We invite the board to work directly with our coalition to keep patient needs at the center of this work. Thank you for your commitment and for giving me the time to comment.
Thank you. The next individual on our list is Derek Flowers. Derek, if you are here, welcome, and you have the floor.
And thank you. Good morning, and thank you for the opportunity to comment. I'm Derek Flowers, and I represent the Value of Care Coalition. We're a network of patient, healthcare provider, and caregiver organizations. During PDAB meetings, we've relayed concerns about upper payment limits from the perspectives of patients, specialist doctors, pharmacists, and even health plans. and therefore we were heartened to see a slate of legislative recommendations in today's packet that take a broader look at policy options. The only reference to UPLs appears to restrict its use to an option of last resort. Even in that circumstance, the policy carries great risks. Still, the people of Oregon are fortunate that this board is considering other solutions that may shine greater light on the complexities of the healthcare system and more directly impact patient costs and access in a positive way. Despite this, it's undeniable that if UPL authority is granted, the current cost reviews and your affordability decisions will no doubt underpin future UPL setting. And so with that in mind, we continue to have concerns with the current reviews. The reports offered build a solid foundation on clinical indications, disease burden, pricing benchmarks, and utilization, but two essential considerations are underdeveloped: the value these therapies provide to patients and clinicians, and the role of insurance benefit design in real-world access and affordability. First, on value, no discussion of affordability is complete without consideration of value as defined by the patients who benefit from the treatment and by clinicians who balance individual risks, comorbidities, and long-term outcomes. Currently, patient perspectives appear only as excerpts from a handful of survey responses, and there's no feedback from doctors in the 5 reports under consideration today. There's little analysis of why clinicians prescribe these therapies, why patients choose them, or how outcomes would change without access to them. This gap risks focusing on price alone rather than overall clinical and societal impact, so more information is needed. Additionally, we urge the board to consider these drugs on an individual basis, not compared to one another, despite how they're grouped for review. It's like comparing apples to oranges. They're both fruit, but that's where similarities end. These drugs being discussed today all treat diabetes, but they're different, and what works for one patient may not work for another. So please consider the value patients and their doctors find in each treatment as you eventually determine your definition for affordability. Second, on benefit design. The reports note the number of plans requiring certain access barriers like prior authorization or step therapy, or drugs in non-preferred categories, or denying coverage entirely. But it stops short of examining how those benefit design decisions expose patients to higher costs. And it stops short of examining the complex system of formulary construction that leads to those barriers in the first place. Without analyzing the impact of these benefit design levers, these discussions risk focusing too narrowly on top-line prices while missing the supply chain and formulary dynamics that ultimately determine whether a patient can start and stay on guideline-consistent therapy. In sum, affordability determinations require a full view of value and of benefit design, the two elements that most directly shape whether patients receive and maintain effective therapy. Refining the reports along these lines will better support affordability, equity, and continuity of care for Oregon patients. I appreciate this board's willingness to adjust as you learn more. Your legislative proposals reflect broader thinking, and adding consideration of the 2 items I flagged here would be further progress. Thank you for your time, and thanks again for the opportunity to comment.
Thank you, Mr. Flowers. I do want to now transition our board discussion to some background related to volunteered trade secret information. Last month, the board received a public comment letter which included trade secret information that was voluntarily provided by a pharmaceutical manufacturer. Today, we will discuss procedures and policies to handle any future volunteered trade secret information. Courtney will lead us in this discussion. So Courtney, Senior Policy Analyst, welcome, and you have the floor.
Thank you. And I need to still screen, Melissa. Hopefully. Are you able to see my screen? All right, thank you.
Yes, you can.
Great, thank you. Good morning, board. As Chair Bailey had mentioned, last month we received a letter indicating confidentiality. And this is the first time that volunteered information has been submitted to the board, and a structured process has not been developed for this kind of information to be received. So I wanted to speak with the board kind of about options, what is in the best interest of the board to do the reviews in a meaningful manner. So to start with, just as a quick overview, according to our Oregon Revised Statute 646A.693, PDAB may meet an executive session to discuss trade secret or confidential information. However, according to ORS 192.660 Section 4, it does allow news media to attend executive sessions. So it gets a little bit fuzzy on how to integrate the confidentiality and ensure confidentiality when media is allowed into executive session. So the question being asked to the board today is, although to look at what other states PDABs are doing and how they allow that information to come in and how it's handled, and what it is that Oregon may decide to do, and kind of what the next steps are. So just as a high level, all the PDABs that offer kind of upper payment limits that have very structured processes for establishing upper payment limits are highlighted in the green. There are other states with PDABs that are based around state, but none of these states have the ability where media is allowed into the executive session. And I see John's hand up, so I'll pause before continuing. John?
My question has to do with Oregon is unique. Oregon appreciates transparency, and I like that. Serving on other boards that also, actually in reference to this topic, struggled the last couple of years as the executive session policy was hashed out in the state government. But it puts us, in my opinion, it puts us on this board at a disadvantage in that, or maybe it's a question, how much transparency are we going to get? What kind of a look are we going to get at the information that we need to see? For example, rebates. And what's the true cost of the medication? How do we see that if we don't get to see this information? How do we do it when we very clearly, the comparison chart was excellent, and I really appreciate it. It highlights the differences that Oregon has versus Colorado, Maryland, Minnesota, Washington. Thank you. It's significant, the differences that we have in the state of Oregon. But my question is, how do we accomplish our best efforts on this Prescription Drug Affordability Board, searching for transparency when we have to work within this framework? I'm not sure anyone has an answer right at the moment, but I'm interested to hear comments or thoughts, please.
And I'm not sure if the board wants me to finish kind of providing updates about what the other states are doing and their processes before answering John's question.
Courtney, I think John proposed a really important question and discussion for us to have, but if you don't mind kind of going through the rest of the comparison to help us dive in a little bit to each of the states, and then we could have that comprehensive discussion.
Sounds good, thank you. So again, as John was just kind of mentioning, Oregon is very unique. We have this public meeting law that allows media to join into executive sessions, where pretty much every other state has the privacy to go in and ensure confidentiality and trade secret information is just within the confound of that meeting. I don't know if there's any way to, get around that, but, as John has proposed, how are we going to, or how does the board want to receive the information that may come in as confidential trade secret, but also ensure, according to our policy and our statute, that we maintain that confidentiality, even if this information is provided transparently. So just to kind of give a high level, Colorado, they do have a closed executive session, and they have a process where stakeholders first email the staff to request access to submit confidential information, and that information is usually done within 21 days. And then the staff will respond within a time frame, and then allows the stakeholder access to submit it. And it just seems to be, and I know some of it here is kind of more based around the UPL rulemaking and hearing, but I think it's still a pretty legitimate process to consider, especially starting with being asked if the PDAB can receive the information, and that we can ensure a process to have it maintained confidential during the process. Maryland also, again, has a closed session, does not allow media in, and the submitter must clearly designate specific information, considering confidential, trade secret, proprietary, and submit a form certifying that the information is not publicly available. And then the board can determine if the information received is confidential, trade secret, or proprietary. Additionally, Minnesota has a legislative outline. Any submissions made to the board related to drug cost review must be made available to the public, with the exception of information determined by the board to be proprietary. But again, doesn't specifically outline a specific process, but they also do have a closed session. And then the same with Washington. They also have a process where they have confidential information will not be shared during the public meeting, and have a process where this through a transfer, like a file transfer link, and is provided through a secured individual and stored separately once the transition has happened. So those are kind of the high level concepts that the other states do. So I want to just kind of end it there and turn it over to the board to kind of start facilitating the discussion.
So Courtney, if I heard you right, coupled with some of the other meetings I've watched and the information in our packet, would it be fair for me to kind of summate that of the states that are able to receive trade secret information, the board members may hear net price and things, but when they go into public session, they may be able to use that information for decision-making purposes in their own minds based on the information they receive, but they're just not able to kind of articulate those numbers when they're in the meeting. So they can hear it, they can use it to make informed decisions, but they just can't disclose it when they're in their public meetings. At a broad level, is that kind of a fair summary of what some of the other states are able to do that are in alignment with their board policies as well as their own respective state laws?
Yes, at a high level, like go into executive session, listen or discuss, but not provide any decision making of the trade secret or confidential information. But when they come out of executive session, it remains, they do not discuss it publicly, and it's not disclosed in reports either. So, and if it is, then it's usually redacted out.
Yeah, I've seen it fully redacted in reports, you know, so thank you for kind of reinforcing that.
And John, I see your hand up.
Yeah, we have that capability in Oregon as well to review information in executive session and then make decisions based on it outside of executive session, certainly not in executive session, without bringing the information out of executive session for display. And matter of fact, we would be prohibited from doing that. The difference, though, is media inclusion in executive session. That is the big difference for Oregon. And I know that, and then you get it opens a whole can of worms of what is the definition of a media outlet, for example. On another board that I serve on that has large contracts, they don't want them, they don't even want the media there for those. And so we have to work to the best of our ability legally to work on that. But how do we do it now? If I was a manufacturer and I had rebate information and trade secret information that could be used against me by my competitor or somebody else, I would be hesitant to display that in executive session, not knowing who the media outlets were or trusting that they are going to follow the law. I mean, I assume that they would. I hope that they would. One thing that this other board has done or thought about doing is to have media register so that you know who your media is that's attending. They sign a confidentiality notice, for example. That's another possibility that we could do. It all comes down to, well, let me back up. The lawsuit that we just mentioned in the beginning of our meeting, does that mean that the information can be collected or will be collected by law? If so, is that trade secret information? And if so, how does the board see that then? Or does it we can collect it, but we can't review it in a meeting? I guess the question.
So there's two different kind of topics going on here. The lawsuit that was mentioned in the beginning is associated with the drug price transparency program in the sense where that is trade secret information, and it was kind of discussed back in 2022, kind of when we first kind of started understanding the requirements with media in and the risk of it, that it wasn't going to be reviewed because there wasn't a whole lot of meaningfulness to bring forward, just with some of the stuff that was not considered trade secret. What this conversation is about is also regarding the volunteer information. So we received a letter providing volunteered kind of confidential, I wouldn't really say it was trade secret, but confidential information that the manufacturer stated. And so it'd probably be, it's a different process because one is coming from a department within DCBS and the other is coming straight from the manufacturer as a volunteered information. And we're not really looking at, we don't have any data from DPT to look at trade secret information, but we may receive more confidential letters and we need to know a process for that. So as it stands, we don't review the information from DPT due to there's no way to confirm the protection of the confidentiality due to media being in, but it's kind of a different gray area with the volunteered information. And I want to give Lori a moment and Dr. Burns. Lori, go ahead.
I have several concerns about this issue. One being risk versus benefit of, we open ourselves up to problems if we mishandle information. We can't mandate the same information to come from everyone, so we're not getting necessarily all the information we may need to make really good decisions and policy recommendations. And also it could be a very time consuming to the process itself, to getting caught up in how we handle everything. And, as we see from our recent advocacy letters and our discussion, there's a lot of issues to figure out regarding affordability, and this may kind of be time consuming to open this. So those are just things I wanted to bring up.
Thank you, Larry. Dr. Burns.
Yeah, I was just kind of wondering about if we were to be able to consider this, it would require a change in the way that the like the rules around the committee has been put forth by the legislature, right? Is that correct?
Well, there's nothing we can really do about the state meeting law, but what we can do is develop a process within our policies and PDAB to the best of our ability. However, still with that gray area that we're not sure how to fully protect the confidentiality or trade secret information due to media being in there.
Would that be something that could be addressed by the legislature if, say, there was a recommendation around that?
I would have to lean into maybe the new executive director or different leadership. I don't have that exact knowledge what our scope of practice would be, but I'm happy to take that and ask what are the possibilities. Can the board make a recommendation to have an exemption or something of that nature of board member or media being in our executive sessions?
And then just one kind of quick follow-up to that. I know that recommendations were posted in the meeting packet for this month. Does that mean that recommendations are closed for board members to put forward?
Oh, no. We have a couple months that we're going to have this discussion. And again, this is kind of like the first introduction to get the conversation going, but I'm sure there will be other recommendations as we continue to have the discussion. So
thank you.
Yeah. Dan, I see your hand up.
Yeah. I like John's recommendation of knowing who the media members are going to be prior to going into executive session and then having them sign a confidentiality agreement. I think it would be confidential for the most part, but it doesn't hurt to have it on paper and to be assured that that information remains confidential.
So how I just wrote down, I'll check into, if PDAB, how we can do it at the, like a legislative level. Otherwise we can look at if there's a process to be developed regarding media signing a waiver of confidentiality. But Chair Bailey, I see your hand up as well.
Thank you, Courtney. I mean, it's my understanding right now that no other board in the state of Oregon has any sort of waiver related to executive session and media. I mean, specifically related to contracting or pricing or anything. So it's my understanding that every other board in the state does operate this way. B, I like Mr. Murray's suggestion that we at least search if there's already existing documentation from other boards that they've used similar, almost like a MNDA or some or NDA specifically about disclosing. But honestly, from my own personal perspective, I'm not comfortable accepting trade secrets when we have media present in executive session. I mean, the previous board chair gave additional detail related to why he left when he left about a year and a half ago, and this was one of the topics he referenced before he left. So personally, I'm not comfortable taking trade secrets as long as we have media present in executive session, but that's just my own personal opinion.
Yeah, thank you, Chair Bailey. John, I see your hand up again.
Yeah, just a question. How much does this affect the effectiveness of the PDAB board? Is this a topic that's absolutely critical that we address, or is this is the information that might be presented to us not critical? It would seem that transparency is a huge issue in the prescription delivery system. There's almost none, and I'll reference additional steps to make it more opaque in our next discussions. But how much of it is needed? How much trade secret review is needed to accomplish our job? And I guess I would say I'm fine with if this board wants to bring this discussion back to next month after we have some additional time to think about it, or other people can be consulted, like legal counsel, DOJ, something like that. I suspect that getting a waiver from Oregon Government Ethics on meeting law is a stretch. I don't believe that we're going to be getting that. So how we deal with it and is probably on us.
Thanks, John. And I'm happy to bring this back to give everybody just kind of some time to come up with concepts and ideas. But before we ask the board to make a decision, I want to listen to Chris and Chair Bailey again.
I think I'd echo the comments of Chair Bailey. I think if it's our responsibility to maintain that confidentiality, Courtney, and we're going to have the press present or media present, it would be hard to ensure that confidentiality, right? If the data is being sent to the board and it's our responsibility to maintain that confidentiality, I think it would be, I would worry about our ability to do that if we had media present.
All right, thank you, Chris. Appreciate that feedback. Chair Bailey, I see your hand up.
Thank you. I think the only thing I would add is just a reminder to all of this, to all of us, that this is identified as volunteered trade secret information. So from my perspective, you could very much go down a rabbit hole of what could just be considered confidential information versus what is, actually trade secret information. Again, this is information that is self-identified as trade secret. So I just personally feel like it's a little bit of a slippery slope until we had significant changes in what we can or can't do as a board. But that was the immediate thing I thought of when I saw the first letter that identified it as such last week or last month.
All right, thank you, Chair Bailey. So I just want to be mindful of time because we have a lot of other things to talk about. I can either bring this back, we can have some clarification next month, or if the board feels that it is best to maybe update our policy number 1, indicating that volunteer trade secret will not be accepted. Anything that's provided to us needs to be transparent and upfront for public viewing as well. And then it can just be associated with the current process of the drug reviews. But again, this is a board decision that I feel that the board can provide the staff with guidance. So we can bring it back, or I can start working on policy language to update the policy 1 on how to do a process with this. Dan Kennedy, I see your hand up.
Yeah, Courtney, I'm just curious, is this the last month, the first and only time that the board has received voluntary trade secret information?
So it's the only time.
So it's not something that happens often, sounds like.
Yeah, the 3.5 years we've been at this is the first time we've had a volunteer confidential information submitted.
Thank you.
Dr. Burns?
Yeah, I guess this is kind of a dumb question, but so I apologize for wasting time. But presumably the people who submitted these trade secrets know that this is a public meeting and that the media is present in executive session. So it's possible that those would be exposed. Like I'm opening that up to other people who sit on other committees and have experienced this, because I mean, it was voluntarily put forward, right?
It was, but it was indicated during the initial email that it was to remain confidential and not posted publicly. So even though it is known that this is a public meeting and we follow the public meeting law, it was still asked not to post it publicly, which is why it was that the letter's redacted so that we could post it without what they indicated were the parts of the confidentiality.
Okay.
So, Chair Bailey.
Yeah, I was just going to lean into that. I think this question was, a little bit of open-ended kind of rhetorical question, because yes, I believe the manufacturer that submitted that to us, right, they were very aware of our process because they've actively engaged in it in the past. And so I would operate under the understanding that they did have a clear understanding of what our public meeting laws are and what our process is related to reviews.
Thank you. John, I see your hand up.
Yeah, I guess I would suggest then that we do not accept, and we publish that we do not accept voluntary submitted trade secret information, because it will either be redacted or shared openly. And if they wish to give a disclaimer that it's okay to publish it, then they just need to know that that is our procedure right now. As far as I may have been mixing two purposes earlier when I was speaking. Data that helps us achieve our mission of deciding affordability throughout the process. It may be different, and maybe it does come from different sources that's scrubbed or put into a complete, well, there's just no identifying details to it. So maybe different than voluntarily submitted. So I guess I would say if we do not have a mechanism for voluntarily submitted trade secrets, they need to be not published and returned or informed.
All right. Thank you, John. I appreciate that. Lori.
I'm in support of John's message that we make it clear that we are not receiving it, and it's such a slippery slope, and we can get caught up in it, and then we undermine our purpose of what we're doing here, worrying about information that we may or may not even need or want. So I'm in support of just clarifying to people that this is our policy and, not trying to make a big change right now when we don't really have the ability to do much until the legislature meets again.
Thank you, Lori. Yes, Chair Bailey.
Could what Ms. Hoagland just referenced be a policy recommendation for us? I mean, is that something we can share with the legislature? Our interest and desire in some executive sessions that may have confidential pricing information that media not be present? Is that more a legislative recommendation or?
I need to take that back and get some advice on what the ability to do that is. So again, I can look into that and bring it back. And then kind of what I'm hearing is that there isn't much support to receive the volunteered information. I can update the policy to indicate that it's not going, just as an example of what the language would be to look at for next month. And then at the same time, get clarification on PDAB exemption from having media in the executive session to see if that's possible. So is that what the board would like? Is drafted policy language not to have volunteered information, but then also look on if we do accept it? Because again, if I just create a draft of language and we were able to get that process solidified by next month if there's no exemption available. However, we can, if there is an exemption, then we can continue the conversation next month.
I think that's in alignment.
I see a couple heads nodding. Okay. All right. So I will thank you all very much for the conversation. I will get that in order and we'll talk about it again next month. All right, Chair Bailey, back to you.
Thank you, Courtney. So we are now moving forward to our board discussion of policy recommendations included in the 2025 annual legislative report. Each year, PDAB provides policy recommendations related to prescription drug affordability for the Oregon legislature to consider. This past month, board members submitted ideas to staff. Today, we will look at board member ideas and begin our discussion about policy recommendations to include in the board's annual report, which is due to the Oregon legislature in December. Courtney will help facilitate us in beginning this discussion.
All right, thank you, Chair Bailey. Get my screen shared here. And I'm actually going to lean into the board members who provided recommendations for this process. But just as a high level, in providing an overview of the prior recommendations that the board has set through starting in 2022, PDAB put forth multiple recommendations. The majority of them had legislative actions to them, and even though some did not move through. In 2023, again, provided the lowering of insulin copays, which was implemented under the Senate Bill 1508. Which capped the cost of insulin at $35 with a 90-day supply at $105. And then the expand PBM reporting requirements, which fell under Senate Bill 192. And then in 2024, this is the cleanup language that was applied to our Senate bill, which changed the language from identifying only 9 drugs to up to 9 drugs per year or per review process. And then the other language regarding the removal of the generic drug report, and then just incorporating that information into the your annual report starting in 2026. And then updating the requirements between reporting from the Drug Price Transparency Program to just do it annually. All the other recommendations did not have actions on them. So if the board felt any of those prior recommendations are essential or can can be improved to expand on for legislative actions, we can look at those and consider those. Otherwise, I asked board members to submit concepts for today's discussion. And again, board members, if you have any other recommendations as we kind of discuss this month and next month, this is the opportunity. And please email me if you have some by next month so we can have a meaningful discussion to get these recommendations into our end of year report due in December. So John, I'm going to kind of lean into you starting this off. And the recommendations that you provided, is there any one that you want to kind of focus on or anything you want to kind of express to your colleagues?
Yes, I would like to start actually with one toward the end. Number 7 on my list, institute 1 PBM for all Medicaid and managed care patients in Oregon to be selected through a bid process, which emphasizes efficiency, reduced taxpayer costs, access for all Oregonians, and maximum transparency. It seemed to be a common theme with maybe some of the other board members that submitted recommendations. And recently I spoke, as I mentioned earlier in the meeting, with Trevor Douglas, and Oregon. His comment was, if you've seen one Medicaid program in the nation, you've seen one Medicaid program, meaning that each state is very, very different. And I appreciate the differences. I understand, maybe don't appreciate always, but understand that there are differences. And so where Oregon has already started somewhat this process, I would like to recommend, and like to have a robust conversation here with members today, what this could look like, what other members of the PDAB feel about this. Other states have implemented these things, and there can be, for example, Ohio, and there's going to be discussion about the different effects of that. Some articles say they had $140 million savings. Other articles say, well, no, there was no savings, but access increased, and many other positives came from it. So I guess I would like to hear from other members that may have felt that this was something that needed to be done or should be recommended, should be recommended to the legislature, where we already partly have these this mechanism in place. You know, I was reviewing the Lund report that was published in 2023, December, where the CCOs, for example, my CCO in Eastern Oregon between those years took $62 million out of the Medicaid system as a dividend. Well, we have the worst access in the nation right now for pharmacy per capita. I think we're headed in the wrong direction. I saw the letter from PCMA. I saw the letter from Regents, Blue Cross Blue Shield, both of those submitters, and then Lugina spoke earlier this morning, both of them, and Robert Judge, a former PDAB member, all 4 of those testified on February 4th, 2025 against any changes to the system in the state of Oregon for various reasons. Again, to expand on that, and my comment earlier about increasing opacity in our drug delivery system, one of the suggestions for the short session is, hey, why don't I sponsor a bill, this was a legislator, that does MAC plus $5 copay for the Medicaid program, critical access pharmacies only. And on the surface, that might look good in that it increases from 71 cents dispensing fee, when the OHA's study demonstrates anywhere from $10 to $16 is needed for a dispensing fee for a pharmacy to stay open. 71 cents to $5 might seem like a great improvement, but you know what it does? It institutionalizes, puts into law MAC, which is a purely PBM regulated cost figure. They don't have any transparency to that figure. There's multiple PBM MAC lists, and they can adjust that MAC list down or up however they feel they need to. So anyway, I think one PBM for all Medicaid and managed care in Oregon with maximum transparency through ArrayRx, if that's the one that we might suggest, would be a great idea. I'd be curious to hear what other board members feel.
I wholeheartedly agree with what Mr. Murray referenced related to a policy discussion. I've, just for the record, have been in communication with people, pharmacy owners and others in Ohio, not related to PDAB work, but just in my own career. And it does seem that that is a mechanism that for that state has very much saved money to their general fund and improved access specifically in their rural communities. And so, and there's many other states. Some of that's documented in the UPL report we did last year under additional information. But I very much, and that also was one of the recommendations from the Secretary of State report that came out a couple years ago. So I would wholeheartedly believe strongly that that would be one of the recommendations that as a PDAB we should explore including on our policy recommendation roadmap for the legislature. Mr. Kennedy, I see your hand is raised.
Yes, I just wanted to speak briefly. I'm in full agreement with John. I think right now in the state of Oregon, with all the managed Medicaid networks we have and everything, we have at best a patchwork of different plans with different payment systems and everything else. And I think if we could get one PBM for all Medicaid and managed care patients in Oregon, I think it would increase efficiency greatly. So I think it would ultimately save the state of Oregon significant amounts of money, would increase access. And if we could also ensure that that PBM is reimbursing pharmacies with an appropriate dispensing fee, we could really help access significantly as well. So I think John's was better thought out than mine, but we're on the same page here.
I think for the record, I would want to lean into what was referenced by Mr. Murray, but also say some of the things that, from my opinion, go with that would be examples such as number 9 that Mr. Murray articulated related to a verifiable cost figure plus the OHA dispensing fee schedule. For those that are listening in that may not be as familiar with Oregon, we do have published average actual acquisition costs, and I believe we've had that since like 2011 or 12. So it's a mechanism and process that we do have in place for managed Medicaid. And so I do think that I think if I'm understanding Mr. Kennedy and Mr. Murray, we're not simply only asking for one, PBM for managed Medicaid, but we're also looking to interject in that other drivers that can improve access and affordability and reduce cost. But again, also kind of using a verifiable cost figure plus the OHA dispensing fee. But Mr. Murray, I see that your hand is raised.
Yeah, transparency, transparency, transparency. Let's add as much as we can to the state of Oregon's delivery system. If we cannot go into ERISA plans, for example, we cannot go into or choose not to or can't get political muster enough to go into commercial plans, let's go into Medicaid and managed care and see how this works. Every single pharmacy in Ohio signed up to be a part of this program once they instituted it. The access went through the roof. The qualitative, the Milliman report, somebody will quote and say, well, gee, there was really no savings to the state. Well, how about patient care? Patient care went through the roof as far as access and ability to serve the patients of Ohio. Oregon, this is one of Oregon's biggest problems, service to Oregonians and access to, whether it's inner city or urban or rural or frontier where I practice, pharmacies are going out and it's the Oregonians that are suffering. And we need to put more transparency. We need to put more qualitative success to this. They're going to argue, I'm sure detractors are going to argue that the Ohio program did not deliver what they say of $140 million in 2 years, $140 million savings over the first 2 years of the operation of a single PBM. Well, they can argue that all they want, but the other untangible or useful things that happen because of it are all positive. When I say transparency, having a transparent, maximum allowable cost list manipulated behind the scenes for PBMs to raise or lower based on nothing more than what they want. We have had pharmacies, multiple pharmacies owned by one owner. The same drug dispensed on the same day, same quantity, same reimbursement formula, paid differently because the MAC lists differed. They just modified them depending on, I don't know what, but they, would think that that would have stayed the same, but there's no consistency, and that's the whole purpose of it. I would also argue the rest of mine, which we can go into here in a moment if other people want to still talk about this topic.
Mr. Lehman, I believe that you had your hand raised next. You have the floor.
Yeah, I was just going to say, Chair Bailey, I mean, it sounds like we're all in agreement, or more. I mean, we haven't heard from everyone, I guess, but with number 7, I mean, and I would just verbally support it. I hesitate to add too much in there with the other pieces that we were kind of talking about adding, but I think that very clear recommendation I would support.
And Ms. Hoagland, you have your hand raised. You have the floor.
I'll keep this simple. I also support, and I think simplicity will drive costs down. And yeah, I think it's really important that simplicity also increases transparency. So yes.
Thank you, Ms. Hoagland. When I see number 6, and then Mr. Murray, I see that you raised your hand. I think of Montana. I think even Montana, as of like October 15th, has moved to commercial transparency with a minimum dispense fee that's in alignment with OHA. So, Mr. Murray, that's something that I just immediately thought of while managed Medicaid was the initial topic of your discussion. There are states, that are also working on commercial transparency. It's my understanding that there's, approximately 25 to 27 states that have some mechanism of kind of your overarching comment, which is related to transparency, whether that's passed through with administrative fees, with minimum dispensing fees, or some type of combination. But certainly many states have had the political gall to be able to move some of these types of initiatives forward. Again, I recognize that was not what occurred in Oregon, but that does not mean it is not possible. Mr. Murray, your hand is raised and you have the floor.
Thank you. I think that if a single PBM for Medicaid and managed care was implemented, certain other of these recommendations might fall into place. On February 4th of this year, and at the Behavioral Health and Healthcare Committee, I actually heard that spread pricing by a plan in Oregon was counted on to help pay their PBM bill. First of all, I would say your PBM bill is too high. Second of all, if you're using spread pricing, which artificially inflates the cost of medications to the plan, is your way of paying PBMs because they get to keep that spread pricing, we have a seriously flawed system. So if we are able to implement one single PBM, they may use a few of these things. They may use a single transparent cost figure that's identifiable to pay the pharmacies in their system. So I guess I will, I'd love to delink PBM fees. I'll just add one more comment. I would love to delink PBM fees from the price of the drug or other fees, rebates, and instead institute service fees for PBMs and remove the incentives for PBMs to prefer high-priced drugs. I think it will save money in the system. I think it will not encourage PBMs to emphasize high-cost drugs. The reason that I have to have brand name, whatever it is on the shelf, is because one PBM requires it because they get rebates or kickbacks based on their negotiations. So the generic is sitting right next to it. It's half or a third or a quarter of the price, but I still have to stock the brand because of these agreements. So I think that there's room for improvement. I would actually like to, and I asked, I'm not sure how Mr. Douglas feels about it, but I would love to have a presentation from Mr. Douglas next month. Ask if he would be willing to come talk to us about how his ArrayRx system which just added Arizona, by the way, an additional state to the consortium, how that would benefit the state of Oregon in savings and efficiency and transparency. Thank you.
And Vice Chair Dr. Burns, your hand is raised and you have the floor.
Yeah, just a really quick point of clarification for John. Behavioral health medications are carved out to the state. So fee for service provides all of those. So that wouldn't be attributed to managed Medicaid. Thanks.
In one follow-up to Mr. Murray's comment related to Trevor Douglas, I do know, and Trevor, if you're here, sorry, we're all chatting about you while you're listening in, but I do recall, you know, when at the inception of the board, you know, we had a brief presentation related to ArrayRx, but I certainly second what Mr. Murray referenced about learning more, you know, as we discuss these policy recommendations. I think that would be a benefit for the board to hear.
Okay, I can reach out to Mr. Douglas and see what his availability is and the options for the presentation. See if we can get him on in the next couple months.
Thank you for hearing that and for documenting that, Courtney.
So really appreciate the conversation. I know that at least 7 for sure, and looks like 6, possibly 9, as you said, they kind of will fall into each other. As we set this up, is there any other ones to kind of focus on, or some that are not meaningful to move forward? Yes, Mr. Murray, I see your hand up.
This is an initial discussion of policy recommendations, Courtney, is that correct? This will be continued next month?
Yeah.
Okay. Because I think Dr. Burns had some questions or some things that she might want to bring next month. If I'm speaking out of turn, Amy, please say so, but we definitely want to hear from all. Dr. Hartung had one that I'm interested in hearing what the reason is for it and the applicability and the importance of it. Number 2 on his audit of 340B entities. So I would like to continue this conversation, please.
I don't really have anything to contribute. Thanks.
Mr. Kennedy, your hand up.
Yes, I just wanted to once again follow up on John's comments that yeah, we need a reference point that is transparent and fixed and not that is a national transparent point like the NADAC system. And we also need something that would give pharmacies the ability to not dispense a medication if they're paid below their cost. Because right now, pharmacies are largely going out of business because of brand name drugs that they're getting paid significantly under their cost to purchase, their actual acquisition cost. So that I know that's something, and right now contractually, they have no choice but to dispense it. And I think that is a travesty.
Thank you, Dan. So from what I'm hearing, kind of bring this all back to have a discussion, especially Dr. Hartung, so he can facilitate around the audit of the 340B entities. Chair Bailey, before we wrap this up, to go into the next, is there anything within your recommendations that you wanted to highlight?
Yeah, thank you. Some of those were more just notes from other things I had shared previously. So I do believe I'm not sure why I had it in the version I gave to you, Courtney. I think scratching the public sector program for reverse auctions wasn't really in alignment with the intent of what I was wanting to focus on. I believe kind of number 1 is essentially similar to some of the commercial bullet points that John had in his original references. I was just referencing states for my own personal notes. I do think the most recent Vermont law is very much in alignment with the checks and balances of the Consolidated Appropriations Act that I had focused on when we had our UPL discussion about broker fees and the disclosures of those fees. I would encourage everyone to read the most recent Vermont law. I think that's to some of the points we heard during the public comment section. There, although we are definitely talking about PBMs and believe that personally that is a contributing factor to sometimes lack of affordability or access, I personally recognize there are other pieces of the supply chain, and I do think enhanced visibility and state kind of requirements related to broker fees and disclosures of those fees, specifically for public employees, is something that I think we very much should have a discussion about. I'm long-winded, apologize for not breathing during that. Number 4, I think, is just a little bit of a regurgitation of what Mr. Murray provided. So Courtney, if you could go to the next slide that came from me, I would appreciate it, just so I can, yeah, a lot of this was very much more just notes, but I will lean into number 7 and point of sale rebates, such as West Virginia. I know we had some discussions about that in our previous year, but again, I think very much in my personal opinion, trying to link the net to what the consumer's actually paying for the drug is something that I think is an important discussion to have. That also includes, related to point of sale rebates, what the pharmacy purchases drugs for, so that the pharmacy is able to purchase medications at least as good, ideally better, than what the net is, so that they don't have negative margin claims, because I very much believe that that impacts access and ultimately affordability. But much of what was in number 8, we've kind of re-identified earlier in our discussions. But Mr. Murray, I see you have your hand raised, so you have the floor. Although we cannot hear you.
Thank you, Chair Bailey. This is just a general comment addressing some of the criticisms that our suggestions or policy concepts for discussion do not fit our PDAB mission. I would like to also add that we discuss a recommendation to the legislature that we expand our focus on the PDAB to allow such discussions if, in fact, which I disagree with, that precept that we can't discuss these things, but I would like to clearly define or ask for definition from the legislature that we have this authority to discuss these aspects of the drug delivery chain in regards to our Senate bill authorizing our creation. Thank you.
Thanks, John. Anything else, Chair Bailey, you wanted to wrap up? Otherwise, I think Dan Kennedy had this email.
I do have one thing to say, but let's make sure Mr. Lehman has the opportunity to have the floor, and Mr. Kennedy.
Could we formulate something like to word what John just said? Because in my own sort of scribble about the discussion, I think that would be really helpful to get the legislature's approval so that we can, I know we already have a lot of time constraint with just doing the reviews, but I think it would be great to have more discussion about policy recommendations that could reduce costs or improve affordability in the state if we're having those discussions and learning about all these things throughout the year, instead of just having a meeting or two at the end of the year where we're talking about, you know, these things and trying to get it all ready for the final recommendations. I didn't articulate that well, but I think you get what I'm saying.
Yeah, Mr. Lehman, you were reading my mind. I think that's, I think one of the overarching things that I've taken away from the meetings that we've had, since the inception of the board, is that the board does have subject matter experts who are interested in doing things that help improve affordability throughout the state, but that our current statute may limit some of that work that many of us would like to participate in. But I see, I think, Mr. Murray, you may have had your hand up first, so you have the floor, and then Dr. Vice Chair Burns. We can't hear you, Mr. Murray.
Sorry. While I respect the foundational principles of the PDAB and other PDABs around the state, as I commented in one of my suggestions, I see UPLs as the last resort. I think that legislators would value discussion from this board and hopefully take it to heart, and maybe even ask us to present our discussions and our findings to them. It might be nice for them to get guidance from some organization that has studied it and talked about it in a fully public way. I'm not saying that it's going to be, we were kind of accused in one of the letters of being loaded with pharmacists or one-sided opinions. Well, we can certainly make this a public discussion throughout the year, should we have the ability to do that. I think it would be valuable to the state and to the whole drug delivery system. I think that it's also a good idea for the Oregon PDAB board to chart a new course for PDABs in the nation, not just focusing on upper payment limits, but really looking at the drug delivery system in their own state. Where are the problems that exist? Much like the comment, if you've seen one Medicaid system, you've seen one Medicaid system. I understand that every state is different. So I would like to take and suggest that the Oregon PDAB board expand its scope and really study the system that we have in Oregon for improvement. Thank you.
Dr. Burns?
Yeah, so one of the recommendations I was going to make, since all of the recommendations, or most of them, seem to be focused on Medicaid, which is, understandable, I suppose, although I find this is unusual since none of the conversations that we have during the year are about that. But my recommendation would be that they form a different committee for that. But if the board wants to go in the direction that we expand for those conversations to happen here, then I would suggest that we need to have a look at who sits on the board, because we're not well represented to have that conversation. We're coming at it with a very specific focus, and that's not wrong. And I don't disagree with a lot of what, is being put forward. And I understand the thought behind it, but we don't have the right people on the board if we want to have that kind of conversation. So if we're going to make that recommendation, then I would say that we also have to recommend that we look at what was written into rule on who sits on the board, and we would need to expand that and change that if we're going to pull those conversations into this board.
Dr. Burns, thank you. The one thing I did want to clarify for the record, as a follow-up to Mr. Murray's comment, is it is my understanding the board, although UPL came up on this worksheet, it was simply it simply came up as a previous recommendation of the board years ago, which we did fulfill our statutory requirement of providing the report related to UPLs to the legislature, which at this time, it is also my understanding that they have not advanced. So I just wanted to reference that. That was my understanding of why it was on the list, not that it was a recommendation of anyone on the board, but just simply that it was reference information for things that occurred historically. So Courtney, back to you, unless you hear from more of us here.
Thanks, Chair Bailey. And I believe Dan Kennedy again had the same kind of thought with a single PBM in Oregon. So we will bring these back with some of the highlighted suggestions for the recommendations, and then the removal of Chair Bailey's request of number 2. And we will get the recommendations put forth next month. So, Chair Bailey, I'm going to send it back to you to set up for the next topic.
Courtney, thank you very much. I do want to reference, we are moving forward to our discussion of board review and methodology for drug reviews and scoring rubric and worksheet. Last month, the board discussed the methodology documents for the drug reviews and suggested several changes. Staff updated the documents and brought them back before the board today. So Courtney, a senior policy analyst for State of Oregon, you are now welcome back to help provide us with the updates related to that initial rubric that we had some discussions on last month.
I think Chair Bailey.
Oh, I skipped a section. That seems to be with things I've done in the past. All right, so actually, I believe I'm working on an older version of my notes. So Courtney, could you help guide us through what the next piece of our agenda packet is while I pull up more updated notes?
Absolutely. So we have an updated roadmap kind of the process of the reviews. So to get started, we're reviewing drugs for group 3, which are the anti-diabetics, and then next month we will dive into the insulin products. The concept is to not receive any more survey information and kind of finalize the material packets for November, December, with decision making happening in January. The intention would be November and December, look at the packets again and really facilitate a conversation for the drugs. Now that you've become familiar with the material packet, if the board so chooses, using the rubric as a tool to kind of gauge what drugs may provide a need to continue to review, and those that may just fall off because they no longer meet the either statutory requirement or the requirement under our rule. So, and then with the extension into next year, the board is able to make the decisions which fall into our new legislative language, which is to identify up to 9. So you don't have to meet that exact check mark of identifying 9. The board can select up to 9 drugs that you may identify to create an affordability challenge within the healthcare system or patient out-of-pocket costs. And then that will be put into a drug review report, and then the final report being done in March. We still have our annual end-of-year report, and that report will include price trends, the subset list of drugs currently under review, and then the policy recommendations from the discussion you just had, and then kind of a progress report about where the PDAB has been and the work we've done over the last year or so. Again, with the review of that report being reviewed by the board in November, with the final being submitted by the end of the year. There's 2 portions of recommendations. So the recommendation conversation we're having here is best aligned to fall into the annual end-of-year report. However, once the drug review process is completed, if there's any additional recommendations that the board can come from, and kind of leaning into what Chair Bailey said about the upper payment limit study, there are concepts in the upper payment limit study that may support an improvement to the drug to send to the legislators. So any questions kind of about the timeline of the review process going forward, since we had an extension into next year? Okay, so just a highlight again.
Sorry, Courtney, just one quick question.
Yeah.
I apologize. How will the fact that we're sort of working on the report through February of next year affect our ability to do next year's responsibility for the review, I guess, would be my question.
So again, we do have another review process. We just received the data, we're getting it cleaned up. So you will be viewing that preliminary list probably in February. So we'll have the draft of the report to look through during that meeting, and then start the initiation. So it's going to kind of be how it was this year, where review the drugs in February, really start drilling down with the decision, hopefully no later than April, send out the data call, and then come back to this point. I know it's really tight kind of process, but hopefully as we kind of solidify and get used to the drug review structure with using the dashboard and stuff like that, the decisions will be a lot quicker this time. Did that get your question answered for that? Okay. Perfect, thank you, appreciate the question. So again, just as a highlight, we reviewed group 1, which included the migraine headaches, cardiovascular agents, and the antipsychotic. Oops, sorry. Group 2 was the anti-asthmatic, anticoagulants, dermatologic, and then the digestive aid Creon. Again, this is group 3 we're reviewing today with the anti-diabetics, and then insulin products focused on glargine for next month. And then I do want to take the opportunity, I'm going to stop sharing, and then I'm going to roll over to discussing the updates to the rubric. So as we start digging into the reviews of the drugs, we did apply updates to the rubric in orange, and then I just provided some notes of what was updated. Is there any feedback, questions, or clarification that is needed for anything within the rubric? Again, knowing that primarily I included language for patent expirations and the MFP. And I believe there was a public comment about the indication of the ranges. And just for board's content, the ranges come specifically from the data set of what we're working with. So we took the data set and we created those ranges based off of the number or the percentages within the data set. It's not a hypothetical range or anything like that. So with that said, each review will probably have a variation of ranges. If, for example, we have drugs that are more than, if this is a larger number, then we'd have to kind of change these numbers, either the cost or the percentages up or down, depending on what drugs we're working with during that review. But for these, everything is based off of the data set that is now in our dashboard. So with that and the updates, and again, appreciate the board members who helped review this information and provided feedback. Is there anything before we kind of start applying this concept into the review process that the board would like to work on, have improved, or clarify? Dr. Lehman, I see your hand up.
Yeah, Courtney, could you just walk me through the utilization piece? Because in my head, I was trying to understand how, if there's less patients, it's a more severe impact, just so I understand it.
Yeah, so basically, and maybe this will be a good conversation for the board. So as I was kind of developing it, usually if a drug has low utilization, but then high cost, there may be considered an impact. I'm, again, with this section being new from last month, having that guidance. But anyways, if only 2 or 3 patients or less than the 3,000, if it's also associated with high costs, and it could possibly impact access or patient costs. But I'm happy to work with board members to see if we can find a way to clarify that.
Yeah, I don't know. I just wanted to make sure I understood it. So when I was assessing that one, I was understanding it, and I didn't feel like I did. I don't know if that was Dr. Hartung who had called that out, or if...
Yeah, and again, once Dr. Hartung gets, is back next month, maybe we can ask him for some clarification on what the ranges could be to clarify. But
yeah, Dr. Burns, can you help me with that one, maybe?
I don't know. I was looking at it too, and I'm wondering if he had a citation for it, because I doubt that he created it, right? So he's basing this off of something. I know he is. So we need that citation to know exactly how this is being formulated. Do you have that, Courtney?
I do not. And so these were put in by staff due to the ranges of our data that we have and the percentages that were kind of in alignment to like the payment of cost. So we can have Dr. Hartung kind of see if he can help clarify that separation that was requested from last month. But when we looked at the data and the numbers of utilization that fell into the ranges that were similar in comparison to like enrollee burden and cost of the impact, those all fell into the similar percentages. But I will find a way to clarify that a little bit more. And again, unless you as clinicians and pharmacists can provide a different way or a clearer way to describe utilization for this drug review, staff is happy to work with it.
Well, it seems a little bit arbitrary. That's why I'm wondering about it. And it may be that it's based off of like a percentage of the population in the state, and that's where they came up with those cutoffs. I'm sorry, you. But yeah, I would be really interested in hearing what Dan has to say, because my suspicion is that it's, that he's bringing his ideas from an evidence-based model. We just don't know what that citation is.
All right, we can bring this back for next month for sure. Is there any other domains or scoring descriptions? Chair Bailey, I see your hand up.
Courtney, can we go back to screen share mode, unless this is just an issue that I'm personally having on my end with Zoom? But I did want to go back to the piece of that ranked how severe based on the therapeutic alternatives.
Okay, are you able to see my screen?
I can see your screen now. Thank you. I was trying to find it there. And then, okay, so I'm seeing the language. Can we go up to where I can see the name of the column again now?
Oh, yeah, the domain.
Yeah, I mean, I just wanted to lean into something that I've been reflecting on based on some of the comments that we previously received, and now back down. Okay, thank you. I do want to recognize, and I know I shouldn't say a comment without a helpful suggestion, so I can't say that I'm at the helpful suggestion period yet. But I just have really been pondering the comment that just because a drug doesn't have, if the drug, never mind, I'm going to redact my comment. We'll just move forward. Sorry about that.
No worries.
I was thinking of it a different way, and so correct my thoughts.
Okay. So short of the utilization needing further discussion with the assistance of Dr. Hartung, the board, you seem to be supportive of how the rubric is set up and the concept to use it as a tool and as an assistant to move forward with the packet reviews. If that's the case, then I will stop sharing and pull over the packet so we can start kind of discussing those. So please bear with me.
And Courtney, I did want to lean into the fact for the record, since one of our colleagues wasn't here for the last meeting. But again, this is just, we had a lengthy discussion about how this rubric could be a tool to use, but wasn't necessarily something that, was kind of like the quantifiable answer for each drug. It was just a tool to help board members as they go through and made thoughts related to things and help facilitate discussion.
Thank you, Chair Bailey, for clarifying the intent. So starting with Jardiance, it was requested to have additional information added into the review summary that included the kind of the approval year, number of patents, the patent range of dates, any exclusivity period, and then if it was on the MFP list, and then the year of effective date.
And Courtney, can I just stop you to say that you're showing all of this to us as an example of the changes you've made, not that we're starting our full discussion related to Jardiance, right? You're just showing us that there were some modifications that we've made to the style of the packet. Is that your intention?
Well, kind of both. I'm going to point out where some of the updates were, but if there's any key data points or any key information that the board wanted to just pause and have a discussion about, this is a good opportunity. And I apologize, need some. So then going down, again, utilizing percents of the therapeutic against the identified drug. Changed up how to look at cost of enrollees compared to therapeutic alternatives. And then in both Jardiance and Rybelsus, I put in 2 examples of tables on how to implement the rubric consideration. So under Jardiance, the example shows information that is directly associated within information of the packet. And so that includes the exact number of claims, the gross to net, the enrollee burden. And then if we look in Rybelsus, this language is taken directly from the rubric. So again, it shows the ranges and then some of the utilization numbers. So staff really needs to know from board what your preference is. So as we set up all the material packets to be consistent and cohesive for the November and December and January reviews, we would like to incorporate this table, but with these two different concepts. What would be most meaningful for the board to have or show in the packets? And I'm happy to go back to Jardiance if you wanted to see the other one. Do you want the information that's based off the direct language within the rubric, or the direct information within the material packet? If we do this, when you utilize the rubric, you'd have to go in and see kind of where that range falls within the rubric. Otherwise, such as what Rybelsus shows, I apologize for all the flipping, then you could just use the rubric and see exactly what the score is going to be. Yes, John, I see your hand up.
If we have the information already in our packet, it's helpful to me, and we agree on the rubric levels and points, then I like to see the rubric information brought together in one place, please.
Okay, so you want the information from the rubric applied into this example here. Okay. Yes, Chair Bailey, I see your hand up.
Yeah, I was going to say that the Rybelsus example, at least for me, is easier to follow with pulling it directly from the rubric. Again, just keeping in mind that even though we may pull it from the rubric and put it in the packet, again, it's up to each board member's thoughts and research and observation from the packets, how they want to kind of rank things, but just pulling the language from the rubric, I think, is very helpful.
Yeah. Okay, wonderful. Thank you for that feedback. We'll make sure that that example or this table is incorporated in the rest of the packets as we get them finalized. So it is my understanding that the board members have reviewed all the materials of these drugs. Is there any drug to focus on information or any drug that needs clarification for information? Chair Bailey, I see your hand up.
Courtney, thank you. Before we go in, I mean, I guess I just anticipated that we might just start with, I think Jardiance was presented in the packet first, for discussion, but I did want to announce to everyone that we will take a break at 10:30 a.m. Pacific. So I just wanted to announce that for the record before we went into our more comprehensive discussion on each of the drugs.
All right. Thank you, Chair Bailey, for the reminder of the break at 10:30. So again, review background is consistent across all packets. The treatment for Jardiance, again, is reduce the risk of cardiovascular death and hospitalization for heart failure in adults with heart condition. FDA approved in 2014. And board members, please let me know if I need to stop. Chair Bailey, I see your hand up.
Yeah, is there a way we may be able to go just a little bit slower and kind of start at the beginning? I know that all the board members have seen this before, but I think it might just be helpful, as we did in our previous meeting last month, just to kind of keep the screenshots for just a little bit longer, because it may pique something in each of the board members' minds as we move forward in the packets. Does that work for you from a timing perspective?
Yeah, we can work on that.
Oh, okay. I hear the hesitation, so thank you for the flexibility, but or board members, if you feel differently, please speak up.
All right. So again, additional information just provided under the review summary, indicating high-level standard information of the drug compared to the therapeutic alternatives. Price history is provided where Jardiance rose an average of 4.7% from 2018 to 2024, with the additional rise of percentages within each of the therapeutic alternatives. The Brenzaville is not indicated because there was no APAC information, claims information for the NDC used for this drug. And that's why we don't have any data for that specific drug, and why you'll see it's blocked out, because that drug under that NDC that was reported to us was not indicated in APAC. Again, kind of looking at the price concession overview, gross spend was $973 per claim, with the net around $386 per claim. And so the price concession per claim reported to be around $587. Again, showing total expenditures for Jardiance compared to utilization, cost per enrollee, and then cost per enrollee median. Here for patient out-of-pocket cost, again, looking at the out-of-pocket cost per enrollee, the median, the cost per claim, and then the claim median. Under these impact of the enrollees and the payer in their sections within the report, we included the IQR, the 75 percentile, and the 95th percentile for further review. Background information is the same. Quick health inequity update, just indicating that there's some indication of inequity primarily around rural residents having access to medications, and the cost sharing primarily around formulary control due to prior authorization and step therapies. However, there have been some improvements over the last couple of years. Number of prescriptions filled in Oregon. And then within the price for the drug, this is an update based on last month's feedback to indicate the number of units for a 30-day supply. And then those numbers, the 30-day supply, is what calculates the 30-day supply price.
Courtney and staff, thank you for hearing that feedback and for making that adjustment. It's easier, especially when you're going through many of these drugs at once.
Yeah. For here, this table was developed into to show the range across all the therapeutic alternatives associated with the UPI. And then under the pharmacy acquisition cost information, we expanded it to include the annual average of the AAAC over the 4 quarters that it's reported in. And then with that was in comparison to the average unit WAC. For the monetary price concessions, all the information has stayed consistent. The only thing that was added via the request from last month was showing the percent of discount. So for Jardiance, it looks like it was around 60% discounts were applied. Then looking at the average price concessions across all the markets, we had an average of 973 per claim as far as gross, 386 for net, with the 587 per claim with the price concession associated with it, and then across what it represented for each of the markets. Please let me know, board, if you have any other questions. So here's the average healthcare and patient out-of-pocket cost from the subject drug to the therapeutic alternatives. A quick snapshot of what total payers paid, total enrollee paid for annually, and then the payer paid per claim, and then the patient paid per claim. Okay, diving in a little bit more. So this is all based off of APAC, so it's all based off of gross numbers. And then this is again where the updates for the 75th percentile to the IQR is incorporated. So this shows that the 75th percentile, $1,601 was the average price annually compared to the IQR, which was 1,101. And then this is based off of the data call, so these are net prices. This packet did have Medicaid CCO information reported, showing a significant change or year-over-year change in spend for the CCO. And then looking at plan design analysis, 36% of plans required a prior authorization, around 1% requires step therapy, with none indicating it not being covered or it was on a non-preferred formula. Again, this is based off of patient out-of-pocket costs. The clinical review, again, FDA approved information, clinical efficacy. And then the FDA approvals between the subject drug and the therapeutic alternatives. Strengths, dosage, and route of administration. And then going into stakeholder input. That is the end for Jardiance. Does the board have any questions or need to provide any discussion around Jardiance?
I mean, Courtney, one of the things that jumped out at me, and this is more for, I guess, the clinicians on the team or the pharmacists, but it did seem that while the Jardiance out of pocket, on commercial was similar to some of the alternatives from a clinical perspective, it did seem to me that this is a drug with broader indication that can help more types of people with the condition. And so that was something that from my perspective was an advantage that I saw related to the medication. I don't know how Dr. Burns or some of the pharmacists may feel, but that was something that I saw.
I mean, yeah, if you're comparing it to like Invokana or Steglatro for sure, but Farxiga has a very similar profile and similar indications, pretty broad. So although Jardiance does have a number of different indications for use beyond just diabetes, so does Farxiga. And again, I would say they're pretty similar. If you go to the table that I'm assuming the Derm group helped put together, Courtney, with indications, the clinical therapeutic alternatives where it's, a rubric says yes, yes, no, no for the different indications for Jardiance. Farxiga has a really similar profile.
Thank you.
All right, thank you, Dr. Burns, for that additional information. Again, any other conversation for Jardiance before moving on?
I will say, Courtney, I believe that we received 2 letters that I should make sure to reference before we talk about the next medication.
Okay.
So I'll go ahead and reference those now. We did receive 2 public letters related to Jardiance. One from Stacy Fan from Boehringer Ingelheim, and another from Jennifer Hazen, who was a speaker, or excuse me, a patient. So we did not have anyone sign up to provide testimony today, but I did want to acknowledge both of those letters that we received that are posted on the board's website.
Thank you, Chair Bailey. Okay, moving on to Mounjaro. Again, same information, highlighting approved year, number of patents, patent date range, exclusivity, and then the MFP list, and then the effective date or effective year. Showing the average annual rate, Mounjaro showed a 4.7% from 2022 to 2024, with similar percentages between with the therapeutic alternatives. Also highlighting that Medicaid also increased by 4.5% over the same period. Expenditures, utilizations, and cost per enrollee for the payers, high level. And again, majority of this information is similar throughout the remaining packets, as they are all comparative therapeutic alternatives to each other. And then for patient out-of-pocket costs, again, based off of the annual cost to the enrollee versus claim. And again, that 30-day supply, these are based off of packages and not as some of them are based on pills. So there's some administrative or differences in how they were administered to the patient or administered. Average unit WAC from 2023 to 2024. And then compared to the IP CPI. AAAC versus WAC for the 2 years. Price discount showed 46.8%. Again, price concessions across all the markets based off of data call information. And these are net costs. So showing average healthcare and the average patient out-of-pocket costs, Mounjaro versus the therapeutic alternatives. So again, data calls based off of net, APAC, and all the therapeutic alternatives are based off of gross cost. In these numbers, they do include the price of the Medicaid.
Hey, Courtney, something that just, yeah, sorry, I know it's hard when we're all looking at this and raising hands or not. I do have a question a little bit more for the kind of actively kind of working pharmacists right now. When I look at the AAAC numbers and I see the per unit price, that doesn't make sense to me. To me, that's probably for 1 pen on the AAAC side. On the WAC side, before the discount, I see the published number. That all makes sense. But on the AAAC side, from what I know, just going on in pharmacy operations still, that I suspect that AAC is per pen. So it's actually not a apples to apples comparison, but could one of the, like Mr. Murray or Mr. Lehman, could you guys jump in here and help me? Because otherwise one would assume that pharmacists are buying this at kind of half what the WAC is, which I know is not accurate. Can you help me provide some color or fill in the gaps here? Mr. Murray, you have the floor.
Yeah, staff asked me to provide the cost of medication for 1 month or 28 days, oftentimes was the applicable date. And so it's really difficult because each pen, the dose for that week or that day or whatever it is markedly different. They're not apples to apples. You can't compare Ozempic dosing to another medication's dosing. You can only apply a recommended, maybe a starting dose or a beginning or a middle dose, dosing strength to each week and go out to the month. And so that's what was asked, and that's what I tried to provide along with my costs. So I'm not sure if that clarifies.
I'll provide additional comment, but I want to make sure Dr. Burns, whose hand I see is raised, thank you, that provides her answer as well. Thank you.
Yeah,
so
it's gonna be kind of tough because of how it's dosed and agreed, and then how the units are. So I would agree with you here for this particular medication, the unit is 1 pen. But then when we look at Ozempic, it's gonna look different, right?
Yeah.
So It's not, and that it's going to be 3 units for Ozempic, but then how it's dosed in that 28-day period is different, right? So, and it's also because of how they come in the box, right? So it's not, unfortunately, it's not a milliliter or a milligram, which would be really helpful to see. It's more like when you look at inhalers, right? And so you're going to have a real difference of how you look at a unit price for a Respimat versus, a dry powder inhaler. They won't come one, it looks odd, just like when you look at 3 albuterol inhalers. They're all interchangeable, but one's 18 grams and one's 9 grams. And because, so it's going to look really weird.
And I do thank you for that. I was looking at the table, but Courtney pulled us up to the qualitative kind of language. The WAC at approximately the 534 per unit. So that's in alignment with what I saw in the AAAC numbers. So I'll redact the comment, but just looking at the spreadsheet, I was like, wow, something's not making sense. But they've accounted for that here at the bottom of page 9. So thank you, Dr. Burns and Mr. Murray, for that additional content.
I would add just one thing though with the Victoza, because depending on which strength you're using, you could go up to 6 pens in a 30-day period. So, I mean, it's kind of neither here nor there since it's generic now, and the brand pricing really, although relevant for this conversation, is not what the current marketplace is, what's really out there on the current marketplace. But I would point that out, that Victoza is a little different than the others.
Thank you. So Courtney, sorry to take us off based on that, but thank you for helping show the section of the packet I was referencing.
Yeah, no worries. Go back down here. Rating. So then looking at health insurance plans, again, looking at commercial, Medicaid, Medicare, and then the total claims, payer paid, and that average per enrolling per claim was for each of the lines of business. Utilization versus gross expenditures. And then what those costs are per enrollee with the IQR 75th percentile and 95th percentile. And again, all these based off of gross. Looking at net, you have your individual markets, individual, large group, and small group. Then the averages for claims, pay per claim, and then the spend per enrollee. Again, this drug showing up on the CCO greatest increase for year over year. With plan design showing 64% requiring prior authorizations, 35 requiring step 30, step therapy, and then 61 or close to 62% indicating non-preferred formulary, with 1.5% not covering the drug. And then looking at the patient copay cost sharing based off of gross cost. You have your median, IQR, and the percentiles. And then looking at clinical efficacy based off of various trials done. Clinical safety, and then the therapeutic alternatives for the FDA approved indications. Efficacy. Safety and warnings. And then to patient feedback. So as we wrap this packet up, is there any additional discussion or clarification needed from staff to the board members? All right, Chair Bailey, were there any public comment?
Thank you. I was just going to ask you that if my colleagues didn't have any other questions, I did want to read who we received public comment from. So we received 6 letters. We received a letter from Susanna Massaritis from the Community Liver Alliance, from Cynthia Ransom from Eli Lilly, from Carol Elkins, who identified themselves as a patient, from Dr. Harry Gawanter from Let My Doctors Decide, Marianne Cooper, Regents, Blue Cross Blue Shield of Oregon, and Jennifer Hazen, a patient. We have not had past speakers signed up to provide oral testimony related to Mounjaro. And I just wanted to state that for the record.
Thank you, Chair Bailey. Before we go into the next group of drugs, did you want to take the 5 minutes?
Yep, thank you for the reminder. I think that this is an appropriate time to take that break. So we will commence right now at about 10:25 a.m. Pacific. Our meeting will again adjourn at 10:30 a.m. Pacific. All right, welcome back, everybody. It is 10:29 a.m. Pacific, so I guess we may have another few seconds here, but Melissa, could you go ahead and just call roll so we make sure we have quorum before we advance our discussions?
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns. We'll come back to
move forward. Thank you.
Okay. Lori Hoagland. We'll move on. Dan Kennedy.
Guess we may have to pause for a moment.
Okay, I see Dan Kennedy is here.
Present,
Chris
sorry.
Lehman.
Not unmuted, but present, yes.
Thank you.
Present.
Chris Lehman, let's see. John Murray.
Present.
So Amy, Vice Chair Amy Burns and Lori Hoagland. Are either one of you back here in the meeting? We do need one more person for quorum.
Okay. And do we need quorum even though we're not voting? I'm assuming
no, we do not need quorum.
Then let's go ahead and advance the meeting. So Courtney, you have the floor related to helping us start facilitating our discussion related to Ozempic.
All right, thank you, Chair Bailey. So again, starting with Ozempic. Summary overview, showing year of approval, patents, patent ranges, exclusivity expirations, and then if it was on the MFP list, and again, Ozempic and Rybelsus are both on that with the effective year in 2027. Price history showing that Ozempic rose an average of a 4.8% annually from 2018 to 2024. With the therapeutic alternatives from that time period having increased in percentages. Except for Victorza, which had a reduction. And actually, Dr. Burns, the Victorza percent reduction, is that based because it went generic?
Yeah. So in 2024 is when the it went off patent. So I would have, that was my assumption.
Okay. I just wanted to clarify that. Yes, Dr.
Oh,
Kennedy.
you can call me Dr. Kennedy. That's fine. So I'm wondering, because we have an average increase of 4.8%, do we also know what the general inflation rate was for that same time period?
Hold, please. CPU. So 2023, 2024 was a 3.0% for that same period. Yeah, Dr. Burns.
Courtney, you might not know this, but isn't there a current law in Oregon that doesn't allow drug prices to go over a certain percentage, like 10% or something like that? Passed a few years ago.
It can go over, it's just drugs that don't have an increase of more than 10%. If it's less than 10%, then it doesn't have to be reported to the drug price transparency program. But if it's more than 10%, then the drug needs to be reported to the drug price transparency program with explanation of why the increase was above that 10%. I think that's what you're referring to.
Yeah.
Let's see, where did we leave off? So again, cost to the payer, showing expenditures, utilization, cost per enrollee, and then the enrollee median for the drug. And then the cost is for the out-of-pocket for the patient. For a resident. Looking at price history again, based off of package and unit price.
Courtney, I was having trouble. Sorry, I'm just speaking up. I put my hand up, but I know it's hard to see.
Oh, sorry, I have
No,
multiple screens.
you're totally good. So
Yeah.
I was just having a little trouble following on this one down to the graphs that are below. So that to me, when I'm following this, it looks like every year the 30-day WAC is going up consistently for Ozempic. But then when I look at that unit WAC graph and a table that's underneath it, it looked like there was a pretty steep drop in the WAC in 2020, 2021. And I didn't know if somebody could explain that or call out what was going on there.
So this graph actually represents here this percent change, not necessarily what was going on in this table. So if we're looking at this, we look at 2021, Ozempic did have the drop.
Okay, so when I go up to look at the table above that, and that says that that's the 30-day WAC, but in 2020, 2021, the WAC went up for a 30-day supply. So is that graph underneath looking at some different WAC?
No, and it's if you want to come out and clarify for Chris what the difference is. There she is.
Yeah, so the table 4 is based off of the 30-day supply. So that's the WAC numbers based off of that. And then but then the graph below is based off of the unit price. which is labeled on the graph.
Does that answer your question, Chris?
Yeah, but
So this is
it doesn't help me understand how it went down in one and up in another. So did they change the way the unit of measure or something in 2020?
It could be. We don't really have an answer to that right now.
So this is Medispan data,
Yes.
looking at the citations.
Does any of the other pharmacists wonder about that? I don't know, John, like if that makes sense to you. Or
No,
Amy, I don't know.
No, I agree. If it had to be unit change or package, I'm not sure what would do that.
Yeah, I'm not sure either. I was thinking it was volume, but that wouldn't really affect the WAC. That was when I looked at it the first time, like my thought was, oh, Mounjaro entered the market, so their market share dropped. But I don't think that's it because it's about WAC. So it might be worth having you guys having another look at it. It's just at least to be able to explain that because it didn't get cheaper. It wasn't like it got cheaper in 2021 and then went back to the same price in
Yeah, that's what I
2022.
was trying to call out.
Yeah.
I think there's something wrong there in the data probably.
Or somehow someone looked at trying to factor in like a net of rebate that was in 2020 to 2021. Which I guess that'd be low, but
all right. We'll look into that and have it clarified what that drop was. But again, this is based off of a unit WAC of the drug, and then this is based off of the 30-day supply WAC. So, but we'll clarify what that is supposed to indicate. And John, I see your hand up.
Yeah, it's actually about a previous slide, and maybe one of the other board members could help me understand. I'm questioning number of patents for Ozempic is 19. Patent date range is 2025 through 2028. Does any one of the 19 preclude a generic coming on the market for Ozempic in 2025? Any one of them does, Amy? Okay. Okay. Thank you.
Okay. Thank you. Is there any other clarifications? All right. Seeing and hearing none. We'll work on clarifying those graphs, but thank you, Chris, for pointing that out and for clarification. Looking at the AAAC, probably look at ensuring that this is also consistent from the prior column or prior WAC information.
can you go up, Courtney? Sorry to stop you. No, I have it on my computer too, but can you just go? Yeah, I just want to look at the AAAC versus WAC again really quick. So I just want to highlight when we talk about access and affordability, if you look at the annual AAC average numbers, which is pharmacies reported acquisition cost, and you look at average unit WAC, the pharmacy's acquisition cost on the AAC average for 2024 is north of the average unit WAC. So that means there's pharmacy, if I'm understanding this data right, that would suggest that pharmacies are buying above WAC per unit for some of these drugs. Is that in alignment with, I mean, I'm aware of market dynamics and that is, impacting pharmacies right now. And this could paint some of the picture of that, but I just want to make sure to express for the record that I believe the AAC average being north of average WAC in many cases could be accurate, but I just wanted to highlight that. for everyone to see and look at.
Right, but again, Courtney, what does WAC stand for?
The WAC,
Mm-hmm.
the wholesale acquisition cost.
Mm-hmm.
Wholesale acquisition cost.
Right, but so that's not necessarily, so where is the WAC coming from? Like, what is that from manufacturers? Like, who is reporting the WAC here?
We're getting it from Medispan, I believe.
Okay.
And correct me if I'm wrong.
So, and Shelley, I think the point that you're trying to make is that pharmacies aren't being paid what they're acquisitioning the drug for, right?
Or no, or I'm at least actually only referencing the buy side right now. I'm referencing that average actual acquisition cost is supposed to be reflective of what they're purchasing the drug for, right?
Okay, so you're buying it more than what the manufacturer is acquisitioning, like the distributor, right?
Correct. And so that caused me to pause. I appreciate what's going on in the market on the reimbursement side for these drugs, but in this example, if AAC really means the Oregon average actual acquisition cost, it would show that oh, I see what you're saying, Amy, because it's not referencing the payer side of it. But
well, I just want to be really clear in the language because we're
No.
talking so much about the compensation for pharmacies, that we're clear on what part, like where we are and what the acronyms that we're using are and what part of that distribution, like the flow of medications that we're referencing. That's all. I think that you're raising an excellent point, but I want to be clear on where that's happening.
Yeah. No, I see your point. I guess where the piece that was missing on that was, so obviously this is showing the pharmacies are paying WAC, at least the way I'm seeing this, I'm interpreting this as on this drug, the pharmacies are paying WAC plus. Is that how everyone else is reading it? And typically, not for every drug, but typically pharmacies purchase at WAC minus. So that's just something I wanted to call out.
All right, thank you, Chair Bailey.
Courtney, can I ask a question too? Because that's the same time that that WAC graph changes. And so I don't know if there was some unit change there that's not translating over into that AAC. Because if we go back to that, I think it was page 102, there's this big percent drop in WAC. Maybe it wasn't 102 because I think we might have just passed it. Sorry. Yeah, 108. That we were trying to have, we were kind of having trouble wrapping our heads around what that big drop was there, and making sure that the previous three data points on the slide are actually comparing the same thing as those next four data points comparatively. Because I mean,
that's a good call out.
You know what I mean? So let's make sure that the WAC in that table below is really matching the numbers in the AAC, the other number that the pharmacies are purchasing the medication at. It seems like there's something going on there.
Yeah, we can, like I said, we'll go back and double check what's going on with that WAC, especially around that year and then going forward. And then we'll update all the associated tables. Any other conversation on this section?
I mean, something that jumped out to me, I guess not in this section, but was around prior authorizations and things. Obviously, I appreciate the why, but when I know we're not comparing drug A to drug B, these are independent reviews, but I did see significantly higher prior authorization requirements on this than on Mounjaro. And I just, when I was thinking of social determinants of health and things, that was just something that stood out to me.
Okay.
I would think though that that's because we're looking backwards, and in 2024, Mounjaro had only been on the market for 2 years. So I think that if you were looking at the present day, it would probably look a little bit different. And Ozempic has been out for a longer period of time and has had a cultural zeitgeist around it as far as weight loss goes. So, the awareness of it and its placement in formulary structures for all types of insurance is going to be, something that's been there for a while. So I think it's more to do with just how soon things came out.
I don't disagree with that. I mean, the name is kind of becoming synonymous with a Kleenex of the GLP-1 space, right?
Alrighty. And I'll show that table in just a few minutes, Chair Bailey, about what you're probably looking at. So going back, that's the average price concessions across all the markets based off of the data call information. I'm looking at therapeutic alternatives, net versus, I'm sorry, this is not that. This is the additional comparative information. This is net, this is gross, and these numbers do include that from Medicaid. Looking at health insurance plan, total plan paid for claims and enrollees. Comparative utilization and expenditures. The cost per enrollee, including the median IQR, 75th and 95th percentile. And the net cost based from data call information. Again, this drug showing up on the Medicaid CCO as a year-over-year change in price of 0.7%. And then this is what you were referring to, Chair Bailey, this section here.
Correct. Yeah.
Where 70 plus to 71% indicated a prior authorization in 2023 for this drug. So as Dr. Burns pointed out, it probably has to do with as a newer drug to market. So patient cost sharing based off of gross costs. Manufacturer information. Compared to therapeutic alternatives, FDA approvals. Thanks. Any questions or conversation regarding the information in this packet for Ozempic? All right, Chair
Hey, Courtney,
Bailey.
can you go back up to page 35 of this packet? Yeah, 36. Can you just stay there for a second? So if I'm reading this right, the total reported reimbursement for drugs dispensed under 340B was between 0 and 100,000. So 18% said that that was the case. Does that mean that 82% are above 100,000? Like, would I be reading that accurately? The third to the bottom.
This one?
I see. We answer it later. Okay, I got hung up right there and stopped. So we just clearly the numbers don't add up all the way.
I think you cannot answer that question,
Yeah.
Shelley, because it was one of the, I mean, there's a lot of, yeah, so I don't think that was like a mandatory answer question.
Got it. Thank you.
No. Yeah. All right. Chair Bailey, I don't believe that we have any public comments for this drug, but we did have some stakeholder feedback and letters.
Thank you. And I'll go ahead, stuck food in my mouth, but I'll go ahead and read who we did receive the letters from, as well as it appears on the screen. We did receive 4 letters, one from Susanna Masseritis from the Community Liver Alliance, one from Carol Elkins, patient, one from Dr. Harry Gawanter, let my doctors decide, and one from Marianne Cooper, Regents Blue Cross Blue Shield of Oregon. We did not receive anyone signed up to provide oral testimony, nor did we have a past speaker for it. And so now we will move on to the next medication in the packet, which is the Rybelsus.
Okay, so Rybelsus. Again, showing high overview. Rybelsus was approved in 2017. Number of patents, there's 13, with patent date ranges from 2026 to 2039. It is on the MFP list, effective in 2027. Looking at the price history, there was an increase on the average annual price or average annual rates of 4.6% between 2018 and 2024. With most of the therapeutic alternatives also showing an increase, with Victoriza showing the reduction. And just to highlight again that this rubric example will be the one that will be included in all packets going forward. Okay, looking at price history based off of unit and package, 30-day supply. And again, we update Ozempic, we will address the changes in all the packets for the wax as well. Looking at AAAC versus WAC.
And see, Courtney, just as an example, the AAAC versus WAC, that number makes sense to me, right? Like what I'm seeing just operationally makes sense.
Cost of health insurance plans. Again, with Ozempic showing higher utilization for the commercial, Trulicity for Medicaid and Medicare. Okay. Impact to patient. And then the plan design showing 67% required prior authorization with 33% indicating a step therapy is required before the drug will be covered. 60, almost 61% indicated the drug is on their non-preferred formulary. Looking at patient out-of-pocket costs. And manufacturer information. And stakeholder information. Right, any discussion or from the board on Rybelsus? Otherwise, Chair Bailey, you can announce those. I don't believe we have any public comment for this drug
Thank you.
for today.
I will go ahead and reference our letters. We did receive 3 letters related to the medication. one from Susanna Massaridis from the Community Liver Alliance, one from Dr. Harry Gawanter from Let My Doctors Decide, and one from Marianne Cooper from Regents Blue Cross Blue Shield of Oregon. We did not have past speakers on the medication, and again, none signed up today to provide oral testimony. So I believe, Courtney, with that said, the next medication under review is the Trulicity.
Go with Trulicity again. Trulicity to market in 2014. It does not have any known number of patents, patent date ranges, or exclusivity periods. It was not on the NFP list. It did rise an average annual percent to 0.6% from 2018 to 2024. A similar rise for the therapeutic alternatives, short of Victorza. Looking at 30-day supply, package and unit prices. Any questions or conversation for this drug, for this section? All right. Hearing none. Okay, looking at health insurance plans, cost and utilization. Plan design, 76.5 required prior authorization, with almost 12% requiring step therapy, and close to 35% indicate the drug as a non-preferred on their formulary. Then looking at the patient out of pocket for enrolling and then the cost per claim. All right. Not much for the stakeholder feedback. So Chair Bailey, as we wrap this up, any additional comments or discussion from board members on Trulicity or any other packet as we've kind of come to the end? Yeah, Chair Bailey.
Courtney, this is a little more a comment, and I've seen it related to the packet in multiple drugs, not just this drug specifically. But one thing I just want to bring to attention to board members here is like in this example, you know, the annual Medicare out-of-pocket cost for this medication and other medications in the class is significantly more than the commercial out-of-pocket per claim. And again, this is not a comment related to this drug specifically, but I just want to highlight when we talk about affordability and access that the Medicare population is also the population who cannot access manufacturer copay cards. So, and when we think of the individuals on Medicare, this table just really jumped out at me to show it was on page 19 of the packet, I think, at the top. But again, it isn't related to this drug specifically, but just to show Medicare recipients can't use copay cards. And in many cases, the Medicare recipients are paying a higher out-of-pocket. It's actually on page 22 of the packet. Sorry, I'm looking at a different table. It's just something that's been something I've been ruminating on for a long time as I think about things, but it just, when I saw it on this table, it just kind of jumped out at me. I can't say that as a PDAB we can do anything about that, but it's just something I wanted to mention as an observation. It's page 20. Oh, it's page 22. 22 of the packet. Again, as board members, we probably, or sorry, page 22 of the Trulicity section. As board members, we know this, I'm sure, but well, there you go. Sorry,
So 23.
sorry. Anyways, it's something obviously I think as a board we're aware of. It's just an unfortunate circumstance. Because to me, those dollars, not referencing this drug specifically, but just all the drugs except two examples, the Medicare beneficiaries are paying significantly more.
Dr. Burns, your hand up.
Yeah, this isn't a response to Chair Bailey. Just more of a kind of a comment on the cost just for medications in general that we're seeing here. And I've kind of been trying to think of recommendations that we could make that would actually address costs for consumers at the pharmacy, as opposed to kind of the big swing policy recommendations that have been put forth. And I'm not sure if this is something that we can do or not, but I don't know if you noticed, board, when we went through this, that a number of these medications have been slated for the MFP, which is the Medicare Fair Pricing law that was passed a couple of years ago that's kind of rolling into effect. We talked about it a little bit before. I think one of the most successful recommendations that we've had in the past was when we recommended to look at capping insulin prices in Oregon copays to what we were seeing on the federal level for the Medicare Part D program. And so if there's a way that maybe we can make a recommendation, and I'm going to definitely look into this before the next meeting to try and hitch our wagon to the MFP somehow, I think that might be worth looking at and possibly might actually make a difference to people's out of pocket when they go to the pharmacy.
Yeah, Chair Bailey.
Yeah, I hear you, Vice Chair Dr. Burns, with what you're saying on that. I think one challenge with MFP, at least, is kind of the clearinghouse mechanism where pharmacies end up kind of fronting the delta between the MFP price and the acquisition price. And so there's going to be that 21 to 45 day lag in the clearinghouse. So if we were going to have that discussion broader, I don't think we don't have a vehicle for the type of clearinghouse that's being proposed related to related to Medicare, but I certainly hear what you're saying related to that comment. And I saw two hands. I saw Mr. Murray and Dr. Burns.
Yeah, and I guess I would just echo that. You know, we don't know how it's going to ripple through the distribution channels, how the MFP is going to. We hope it is successful, because your point, Chair Bailey, about Medicare enrollees paying more for some of these expensive medications really hits home, and the federal government is trying to address it. I just worry about how it's applied. I worry about it being a top-down answer without understanding how it's going to affect the lower levels, or how it excludes certain portions of the drug delivery system, or how it affects others more adversely. You know, so while I do agree with Dr. Burns about the $35 insulin co-payment cap, fantastic. You're right, it made a fantastic effect for people, everyday people walking into the pharmacy. So
Yeah, I would say I get it. It's a big swing, and it's a recommendation, but I mean, I read through all the recommendations that were put forward, and there was a lot of things in there that are super complicated, and not a lot of understanding of how it would affect the entire system. But we're still going to probably put forth those recommendations. So I would encourage, if we're going to make big swings, and we know that there's a lot of sausage that would have to be made, and we don't actually understand some of the effects that our recommendations might have, that we should at least try.
Thank
you. I was just gonna call on Lori real quick, and then John, you can follow up.
I just wanted to make the comment that when we're looking at this information, and particularly with the medications today in the group 3, and you see that percentage of prior authorization, you realize that a couple of things. One is that there's a lot more patients who would be using these medicines if there wasn't prior authorization. So their numbers are significant. And then secondly, that there's a lot more money involved just with the clinic costs of prior authorization processes that were also, and so I realize that our worksheets have to be simple, but I just wanted to reiterate that impact on Oregon, these medicines are big ones that we looked at today.
And I guess I'm not insensitive to where we have prior authorizations to plans trying to control costs. I understand that that's a need. There's not an unlimited amount of money for this healthcare system to operate in, and so while I do understand that the need for them, step therapy and prior authorizations, when they become cumbersome and used for other purposes, then it is an issue for sure. My comment I was going to make before that had to do with, though, that our recommendations that we might make, as a board to the legislature, they're not unheard of. We have states that have implemented these things. These are not just purely theoretical. There are states that we can go to and say, hey, you implemented this, what happened? So I think that there's more ground to stand on when we make these recommendations than just purely theoretical.
I think Dr. Burns, did you have your hand raised still, or?
Yeah, I just think it would be good to make some recommendations that would actually save costs to the majority of Oregonians, where they could see it at the counter, because that's kind of what we're supposed to be doing here. I understand that we're looking at the whole system, but having recommendations that are really only system oriented and focused on, say, Medicaid, where there are no out-of-pocket costs to patients, seems just like we're only touching one corner of it. And it's, I know that you're coming at it from a very particular angle, and I think that that's something that definitely needs to be addressed. But I think it would be good to have other recommendations. And if we are going to move towards really looking at what you're calling for, which is an overhaul of the state's Medicaid pharmacy program, that we need to have more of those voices at the table, and that needs to be addressed within the charter and the way that this committee is made up.
The CCOs just went to the governor recently asking for more money to support their programs. And so that's in a year where, you know, the transportation bill just went through, and most people in Eastern Oregon who drive are going to feel it. Employers are going to feel it. They're asking for more money. So if we're talking solely about savings to the patient, yeah, they get a zero copay. Savings to the system and the state, however, we need that as well.
Yeah, I don't really think that you understand why the CCOs might have had to go and ask for more money. I don't think that you understand what's happening in Medicaid. And that's what I'm saying. There aren't the right voices here for that. You're looking at this from one particular angle, and I get that, but it's a very big picture that you're trying to address, and you don't have all of the information. So if we're going to move in that direction, and it sounds like that's a recommendation that we're going to make, I'm going to add to that recommendation that we need to have more voices here, because this board wasn't set up to address Medicaid. It was set up to address prescription drug affordability in Oregon, not just Medicaid.
Sure, really.
Well, and I mean, I will say I did hear of the recommendations. While Medicaid, or specifically managed Medicaid, was one of the topics that was referenced. I mean, there were also recommendations related to commercial payers as well. So, I mean, I think what I'm hearing loud and clear is that it sounds like Vice Chair Dr. Burns will be providing maybe some additional information to staff that can be added on when we have our our next meeting, when we discuss this topic, so that we can continue the discussion related to our legislative suggestions. I think as together as a board, we all have different lenses and pieces of the puzzle that we're bringing together related to this, but it sounds like, you know, we'll hear some additional language that we can discuss in future meetings.
And I just wanted to add on to what Dr. Burns was saying about cost savings for out-of-pocket costs with the drugs. So in this process, we can make recommendations when the drugs are selected to how the legislators may be able to look at that drug to have an impact on cost savings. So even if, say, something overall doesn't get implemented for the annual end-of-year report, we can the board has the opportunity to provide the recommendations for the drugs that will go forward or that are identified. So if that's also a concept to kind of consider for the drugs currently under review.
I do want to add, I think though, with our language, I want to be mindful that all of us have gaps and pieces and parts of the supply chain that, you know, we're obviously learning throughout meetings and through speakers that come and present to us, and best practices that we see nationwide. But I guess I would want to make sure, as we're having our discussions, that we keep our comments and things kind of relative to the board as a whole, and not kind of, I guess, to specific members related to any gaps they may or may not have. But Courtney, I do want to make sure we give the medication. I know we kind of went a little bit out of topic related to this drug. So let's go ahead and make sure we do the we conclude this piece of the medication that we're talking about before we move to the next parts of the agenda.
All right, thank you, Chair Bailey. And thank you, board, for the discussion, for the recommendations, for some of the clarifications. We'll update those. And as I said, the intention for the group reviews is to get board feedback and awareness of the drugs that are under review, Next month, we'll be reviewing insulin products, and the packet will probably be looking a little bit different than the standard drugs, because the insulin products, because it's all glargine, will be incorporated into one material packet since the information is so repetitive. So we're just going to kind of break it out and show it all in one packet versus multiple packets. So that's going to be kind of a difference that you'll see from the insulin packet for next month. And again, starting after next month's board meeting, we will not be accepting any more public comment, no more survey information, and those kind of things, so we can create a stationary packet for review starting for the discussions in November and December, and really start utilizing the information that we've been reviewing the last couple of months with these drugs, seeing how maybe the rubric will facilitate some of the conversations the board needs to have to kind of make that final decision in December or in January to get the that report over to the legislators of the drugs that you have identified to possibly create impacts to the healthcare system and patient out-of-pocket costs. Chris, I see your hand up.
Yeah, I have a question, Chair Bailey. I mean, for you, as we get to the end of the year here and it's kind of becomes crunch time to make the decisions around, which drugs we're going to identify as posing affordability challenges, what is your vision for how those last couple of meetings are going to be structured and how the discussion is going to go? I just want to hear so I kind of know and can prepare myself for that, what you envision the format of those meetings being or how things will be discussed.
Yeah, thank you for asking. And I will say, Board Member Lehman, I know when we did have the voting on some of the drugs, I recognize you may not have been on the board when we did some of that, but I guess what in the discussions with staff, it's my understanding that when we do at the end of the year go to voting on the medications, my understanding would be that we all have the robust information that we've had during each of these sessions to kind of personally review. So we will essentially be going through the list drug by drug, and board members will be essentially providing their vote whether they believe the drug does or does not present potential affordability challenges. And then we would use kind of the nays versus the ayes to determine if we have majority on each of those medications, but that we would be doing those one by one. And again, the rubric is a tool that board members may elect to use in part of their decision-making process. But that's my understanding as to kind of how we would handle the final meetings on determining, I guess, the voting for those medications before we decided what we would be advancing. But staff, if I am understanding the process incorrectly, please advise. But Mr. Lehman, it looks like you have a question before staff does
Yeah,
that.
just one point of clarification. So would it be a discussion, a open discussion about each one of them and then individual votes, or are we going to go one by one and vote on each one? Sorry, I just want to kind of understand the way the format will work.
I'm open. I mean, this is just my understanding with staff, but again, as a board, maybe this is something we should be discussing, but we can allow enough back and forth that our time will permit on, maybe why we're voting a way that we're voting or something, but that we would be voting on the medications essentially one by one on whether or not they may or may not present an affordability challenge. I believe the time for the comprehensive discussion on the medications is during the affordability reviews of the medications. But staff, if there is a different intention that I am not aware of or I'm inaccurately representing, please correct me.
Yeah, so kind of bringing it back to the intention of the roadmap. So again, we've been reviewing each of the drugs that were kind of set up in their groups. Primarily going back and re-looking at the drugs in November and December to really get familiar with the information and see maybe how the rubric would apply. Starting in January, the board will need to make the votes. How it's been done in the past is that it's been done individually where we've looked at the drug and it's been a vote, yes or no, based off of the prior conversation. So again, really November and December, just trying to have a very meaningful conversation about each of the drugs. And then January being the one where the votes are applied. And then however I think last time it was just a yay or nay vote, but if there's another way that the board would like to do a voting system, the staff can set something up that maybe make it, more easier, comprehensible for you. But I want to get back to you.
That's really clear to me, Courtney. I think last time we had done it, it seemed like we were voting during the discussion and there were still like more drugs that we were gonna potentially have discussion on or vote. So if that discussion is happening in November and December, and then we're voting in January, that is more clear to me. Is that what you're describing?
Yeah, so it's a little bit different with this process than it was last time. So last time it was
I agree with that. Yeah, and it seems like a better process the way you described it.
Yeah, so last time it was a vote to add it onto the end of year list to then go and make a final decision. So that's where some drugs maybe didn't make the cut, or the board for that month didn't find it to be truly relevant to continue into the review. This time it's more comprehensive. Every drug is it's not going to go on an independent list, right? We're going to do all that in January. That's what November and December, really looking at each of the drugs, kind of seeing how the rubric can compare with some, and maybe if the board is consistent of one drug has a lower score, then maybe it's not looking to cause an affordability impact, right? So it's kind of with that change of having the rubric as a tool to kind of judge the impact for that drug. That's what November and December is offering to the board members. Then when you're in January, you kind of have like your understanding, and then that's where you're voting yes, no, and you're making it off of your decision as a board member. So hopefully that's kind of clear what the structure and process is going to be going forward after October.
Thanks. For me, that was very helpful.
Okay. If there's no other questions, I'm happy to turn it over to you, Chair Bailey, to wrap up the last bit of the stakeholder feedback. But thank you again, board members, for all your time and feedback. And as I need, I will reach out to the board members to have some of the clarification around the rubric language. And if you have any other information on policy recommendations, please get those to me as soon as possible so I can get those updated. So we'll have another discussion about recommendations next year or next month, with a decision on implementing those recommendations into the annual report, either at the end of next month's meeting or first part of November for the review of the draft report. Any questions before I log off? All right, well, thank you all and have a great rest of your month.
Thank you, Courtney. I'll go ahead and finish up related to the appendix of Trulicity. So we did receive 4 letters regarding Trulicity. One was from Susanna Masseritis from the Community Liver Alliance, one from Cynthia Ransom with Eli Lilly, one from Dr. Harry Gawanter, Let My Doctors Decide, and one from Marianne Cooper with Regions Blue Cross Blue Shield of Oregon. They did not sign up to provide oral testimony today. But I do want to also now announce our next board meeting, which is on Wednesday, October 15th, 2025 at 8 a.m. With there being no further business before the board, all in favor of adjourning, please say yes.
Yes.
Yes. Any opposed, please say no. Okay, again, the meeting is adjourned, and please join us next month on October 15th, 2025 at 8 a.m. Pacific. Thank you.
Thanks, everyone.
Thank you.
Great. Thank you.